Bentar. Lavanya is there. Sonia is there. Shruti, Shri, Sanjana, Hema Bharati, Dinesh, Sonam.
Hello, good morning. Am I audible?
Yes, ma'am, you're audible.
Okay. Should we start the program?
Good morning, all. We welcome you all to the YUVA FOGSI South Zone Conference 2022 Salem. Today, we'll proceed with ePoster presentation. We warmly welcome our honorable judges, Dr. Kala and Dr. Ramya. Welcome, ma'am.
Thank you. Thank you.
Ma'am, Dr. Kala will be available after 5 minutes, ma'am. Ma'am said we'll wait for 5 more minutes, ma'am. If not, we'll
Yes.
start.
No, we'll wait for her to join.
Yes, ma'am. Thank you.
Hey Sushma, in this volume only not coming. Yeah, what to do? Okay. Okay. But that sound, nothing that I'm able to hear. Nothing I'm able to hear. No, yeah.
Dr.
That I
Supriya,
increased.
please mute yourself. Dr. Supriya, please mute yourself.
Okay, sure. Sorry.
Dr. Lavanya, can we start the presentation?
Yes, ma'am. Dr. Kala is joining, ma'am. 2 minutes she'll join, it seems, ma'am. We'll start the session soon.
How many candidates are there in the first two sessions?
Ma'am, first two session, 18 candidates, ma'am.
Oh,
First candidate will be Dr. Sanjana Reddy. Second will be Dr. Srisha Marla. Please be ready with your presentation. Dr. Shruti next. Dr. Sijay Andrews. Dr. Sonam. Dr. Soumya. Dr. Shruti S. Dr. Shubhashri. Dr. Shubhashri S. Please be ready with your presentations. Good morning, all. We warmly welcome you to the YUVA FOGSI South Zonal Conference 2022.
Okay, thank you.
We warmly welcome our honorable judges, Dr. Kala and Dr. Ramya. Welcome, ma'am.
Yes, thank you for the offer. I would like to ask questions to the candidates after going through the posters. Are they available?
Yes, ma'am. Yes, ma'am. First candidate will be Dr. Sanjana Reddy. Ma'am, shall we start the session, ma'am?
Please.
Good morning,
I'm
ma'am.
ready.
3 minutes will be given for the candidates to present, ma'am. Next 2 minutes, you can ask them questions.
Right. Thank you, ma'am.
Thank you.
Dr. Sanjana Reddy, you are ready to present? You can start the session. Yes.
Good morning, Dr. Sanjana.
Morning, ma'am.
Yeah, you can present your poster.
Yes, ma'am. I'm presenting a rare case of leiomyoma of the vulva. Introduction. Leiomyoma of vulva is a rare, benign, typically painless, solitary and well-subscribed mass. Less than 160 cases of leiomyoma of vulva have been reported in literature. They are likely to be originating from smooth muscle cells within the blood vessel walls or erectile tissue or the round ligament in the vulva. They pose a greater diagnostic challenge. Case report. A 40-year-old female, para 2 leaving to abortion 1, presented with the complaints of mass in the genitalia since 1 year. Her menstrual pattern was heavy menstrual bleeding with regular cycles. The mass in the genitalia was not associated with pain, discomfort, or discharge. Per-abdomen findings were soft and non-tender, and local examination revealed a solitary, well-circumscribed mass in left vulva measuring 5 into 5 centimeter, firm in consistency, no erythema or discharge noted. Bimanual examination, uterus corresponded to 12-week gravid uterus size, fornices were free and non-tender. The investigations done were MRI, which showed a bulky uterus with multiple fibroids and a large well-defined altered signal intensity mass noted in the left vulva, measuring about 6 into 5 into 3 centimeter, superiorly extending till the level of pubic symphysis, compressing and displacing the lower one-third of vagina towards the right. An FNAC was done on the mass. It showed a benign spindle cell lesion, possibly of neural origin. The management which was done for this patient was hysterectomy with left vulval mass excision. A 6 into 5 centimeter vulval mass was excised completely, which was hard in consistency and it was non-adherent to adjacent structures. This mass was sent to histopathological examination, which was suggestive of spindle cell neoplasm of benign nature, probably leiomyoma. Immunohistochemistry was done, which showed positive for smooth muscle actin and negative for S100 and SOX10, which are the markers for tumors of neural origin. Therefore, a diagnosis of leiomyoma of vulva was made. Discussion. Differentiating between benign and malignant lesions is challenging. The criteria for calling it a malignant lesion is 4 features. That is, the mass should be more than 5 centimeter in widest dimension with infiltrative margins and more than 5 mitotic figures per 10 high power field and moderate to severe cytological atypia. Our case did not have any features mentioned, which suggested a diagnosis of benign leiomyoma. Conclusion is, it is important for clinicians to consider leiomyoma of vulva as a differential diagnosis in women presenting with vulval mass, though it is rare. My references were a diagnostic leiomyoma of vulva, a diagnostic challenge case report, and vulvar myoma case report and review of literature. Thank you.
Good presentation, Sanjana. I would like to know the incidence of vulval fibroma.
Ma'am, in the literature, less than 160 cases have been reported, ma'am. This is the incidence mentioned everywhere, ma'am.
Totally only 160 cases.
Totally, yes,
Okay.
ma'am. In the
Why did
literature,
you do
only
MRI?
one.
Why did you do MRI?
Ma'am, the patient presented to the OPD with MRI, ma'am.
So you didn't ask for an MRI. Is it required then? Will you do?
Yes, ma'am. If
Is it an essential investigation in a vulval lesion?
No, ma'am, it is not essential, ma'am. If FNAC is showing features of malignancy, then it will be essential.
How do you make a clinical diagnosis? Histopathologically, you said probably it is the mitotic lesions, all that. But clinically,
ma'am.
how do you say it's a benign?
Clinically, ma'am, it should be firm in consistency and
No, your case is
no.
also firm. Fibroma will
Yes,
be
ma'am.
firm.
Yes, ma'am.
Clinical features suggestive of malignancy. How do you say? It could be benign.
Ma'am,
You can say, you can guess. It could be benign or
ma'am,
malignant. Based on what?
if it is malignant, it will be fixed and infiltrative margins will be there.
Margin infiltration histopathologically, right?
Yes. Yes,
So
ma'am.
fixity and consistency will be firm to hard.
Yes, ma'am.
And growth duration. Will it
And
be
growth
rapid?
duration will be rapid in case of malignant, and
say the clinical features, no?
yes, ma'am.
Okay.
In our case, the growth was present throughout the year and progressed to the size, present
One
size
last
throughout the year.
Do you require
Yes,
an
ma'am.
FNAC?
Yes, ma'am. FNAC was required, ma'am.
We have
Before
not- right.
Sorry to interrupt, ma'am. Time is up, ma'am.
Yeah.
FNAC was done, ma'am.
Okay, thank you. Next
Thank you.
candidate.
Next candidate, Dr. Shrishma Marla. Please share your PPT and start presenting. Dr. Shrishma. Dr. Shrishma.
Yes, ma'am.
Dr. Shrishma, you're there?
Yes, yes.
Yes. Share your PPT and start presenting.
Yeah. Good morning, everyone. I'm presenting a case of recurrent ovarian torsion. Introduction. Ovarian
Dr.
torsion
Shrishma,
is
your PPT is not visible.
Dr. Lavanya,
Yes, ma'am.
how much of score we have to give?
Ma'am, I have sent you in the WhatsApp, ma'am. The mark.
I have not seen it.
Okay.
Okay. How much per, how many candidates now?
Total 18 candidates, ma'am.
18 candidates.
Yes,
Okay. Okay, start presenting, ma'am.
Good morning, everyone. I'm presenting a case of recurrent ovarian torsion. I'm Dr. Srisha from AJMS. Introduction. Ovarian torsion is a rare but emergency condition. Ovarian torsion accounts for 2 to 15% of the patients who undergo surgical treatment for adnexal masses. Torsion results in ischemia of the pedicle and acute onset pain. Diagnosis is challenging. It's based on history, examination, and investigation. Case study, a 17-year-old girl came to casualty with complaints of left loin pain since 2 days, dragging type, intermittent, non-radiating, aggravated with movements in the same site, not completely relieved with rest, analgesic, associated with 4 episodes of vomiting. Similar complaints in the past, in 2019, scan was done. That time also it was suggestive of torsion of the ovary. Tumor markers were negative. Detorsion of the left ovary, that ovarial vascularity was restored and cyst decortication was done. HPR was suggestive of simple serous cyst. Following which, in November 2022, she had similar complaints and it was managed conservatively with IV antibiotics and analgesics. Examination, it was afebrile, vitals were stable, per abdomen was soft, tenderness in the left iliac fossa was seen. No guarding, no rigidity, no organomegaly, no free fluid in the abdomen, bowel sounds were present. USG abdomen pelvis was done, left ovary was bulky, bilocular cyst measuring 45 into 34 mm noted in the left ovary. Another simple cyst was noted of 1 into 1 centimeter adjacent to it. Color Doppler showed normal vascularity. A twisted pericle noted adjacent to the mentioned cystic lesion that appears edematous and shows no obvious vascularity on color Doppler evaluation. MRI abdomen pelvis plane was done. Uterus was normal in size, shape, and consistency. ET normal, right ovary 3 into 2.6, multiple follicles noted, and left ovary there was a large lesion of 4 into 2 centimeter. Thickened fallopian tube noted, superior lateral to the left ovary, suggestive of left ovarian torsion, which was seen in the image below in MRI. Procedure which was done is laparoscopic left ovarian cystectomy with oophoropexy. Intra-op findings, there was right ovary and right fallopian tube was normal, uterus was normal, left ovary 2.5 times rotation noted, detorsion was done, and left ovary 3 into 2 centimeter cyst was noted. Cyst was excised and sent for HPR. Another cyst of 1 into 2 centimeter noted adjacent to it, and cyst wall excised. Sample sent for HPR. Left ovarian ligament was long, so oophoropexy was done using TRUBAB epsilon 20, and left fallopian tube was noted, which was edematous. The surgical images are shown. One is the left ovarian cyst, second one is the left ovarian torsion, which is seen, third one is the laparoscopic left ovarian excision, and fourth one is oophoropexy. HPR was suggestive of papillary serous cystadenoma. Discussion: the process of torsion occludes the lymphatic
You got stuck, Ma. Hello,
Srisha,
Srisha.
Surgical diagnosis is laparoscopy by laparotomy, remains the diagnostic and therapeutic method of choice if there's suspicion of ovarian torsion. Thank you.
Dr. Shri Shamla, is there any other technique beyond oophoropexy for recurrent ovarian torsion?
Hello.
The presenter is Dr. Shri Shamla.
Marla, Srisha Marla.
Yeah. Is there any other technique other than oophoropexy?
Either based on the age of the patient, either we can conserve the ovary or we can remove the ovary. So oophorectomy can be done, or if we want to conserve the ovary, then cystectomy can be done. Only if there is recurrent torsion, because
we are going to retain the ovary for this girl because she's 17 years. There is no point about removing the ovaries. I'm asking in surgical technique in recurrent torsion, apart from oophoropexy, you said the ovarian ligament was long, you did an oophoropexy. Beyond that, is there any other technique? In recurrent ovarian torsions?
That is same.
No, not shortening of the ovarian ligament. Have you heard of the term hot dog bun technique? Here we take the sutures of the ovarian ligament, leave off the tube in between, take the round ligament and tie these two together so that the lumen of the tube is not occluded, but the round ligament and the ovarian ligament are sutured to each other at the medial end. So usually in recurrent torsions, this is the new technique being followed. So we always conserve the ovary. There is nothing like, if it's very gangrenous, then what will you do for this particular girl?
We have to see the amount of tissue which is detorsion has to be done. Then we can see the blood flow and vascularity and how much is salvageable. Based on that, we have to decide.
Sorry to interrupt, ma'am. Time is up, ma'am.
Okay, thank you.
Next candidate, Dr. Shruti KK. Dr. Shruti.
Hello.
Share your PPT and start presenting. சரி பல்லு தேய்ச்சிரு.
Hello.
Dr. Shruti,
Hello, ma'am.
your PPT is not visible.
One minute, ma'am. Good morning. Myself, Dr. Shruti. I'll be presenting the case of isolated fallopian tube torsion. Introduction. Isolated torsion of the fallopian tube is an extremely rare occurrence in female patients presenting with acute lower abdominal pain. It does not have any classical signs and symptoms which would prompt an accurate diagnosis. The diagnosis usually complete and it usually confirmed only on laparoscopy, where the gangrenous tube can rarely be salvaged. Strikingly, the ovary can be salvaged in maximum number of cases. Case report. A case of 33-year-old female who came with complaint of lower abdominal pain since 1 month, which was aggravated since 1 day, associated with 2 episodes of vomiting, but not associated with any nausea or diarrhea or fever, with regular menstrual history. That day she was day 7 of cycle, and with obstetric history of para to leaving to sterilized. On examinations, her vitals were stable. On systemic examination, CVS and RS was clinically normal. Per abdomen, it was soft. Tenderness present over right iliac fossa, no godding or rigidity. Bowel sounds were present. Per speculum, cervix and vagina looked healthy. PV uterus was normal size in posterior fornix cystic mass. Investigation, it was HB was 10.5. Total count was 9,130. UPT was negative. Ultrasound showed large oblong cystic lesion measuring 73 into 40 mm, noted in right adnexa, abutting the right ovary, suggested of right hydrosalpinx. Left ovary was normal. Uterus was normal size. It was with endometrial thickness of 6.5 mm. Hence, planned for laparoscopic right salpingectomy. Management, laparoscopy was done. Intraoperatively, multiple rotation along the long axis of fallopian tube was noted without any ovarian involvement. Detorsion was done and right salpingectomy was done. It was sent for HPE. Her postoperative period was uneventful and discharged with satisfactory condition. HPE report suggested showed hematosalpinx. Discussion. Isolated fallopian tube torsion is a rare cause of abdominal pain. It occurs most often in ovulating women with predisposing factors, but it has been reported in female of all ages. However, it is more frequent in women of reproductive age because almost all of the risk factors are rare before menarche or during menopause. The numerous etiological factors can be classified as either internal or external. Internal factors include hydrosalpinx, hematosalpinx, fallopian tube tumors, and tubal ligation, PID, and other tubal abnormalities. The later category, that is that later categories, like external factors, includes addition, pelvic masses, pregnancy, or medication. In general, the symptoms are non-specific, and differential diagnosis include appendicitis, rupture of ovarian cyst, ovarian torsion, endometriosis, or ectopic pregnancy, and pelvic inflammatory disease and urinary conditions. Conclusion, although clinical characteristics are not exclusively to the fallopian tube torsion, the most common symptoms is lower abdominal pain, most frequently of sudden onset and accompanied by nausea, vomiting, or urinary urgency. Laboratory values are not diagnostic. Bimanual pelvic examination can reveal cervical motion tenderness or even a hard adnexal mass. In general, the symptoms are non-specific. My references are case report and review of literature about isolated torsion of fallopian tube and isolated fallopian tube torsion are a case report.
Dr. Shruti? Yeah. Yes, madam.
Madam, you continue. Good morning to you.
Good morning, madam. So it was a hydrosalpinx and you diagnosed by ultrasound, Dr. Shruti. Is it possible? Yeah. Here, your case was a hydrosalpinx with torsion.
Ma'am, in USC, the speaker suggested of hydrosalpinx or hematosalpinx, ma'am.
Okay.
But then in intraoperatively, we found that torsion was there, ma'am.
Doppler was done.
Multiple torsion was there, ma'am.
Doppler was done along with ultrasound.
Doppler, no, ma'am.
Can it give us a clue?
Yes, ma'am.
Ah,
Doppler
was it done?
vascularity will be impaired.
Was it done in your case?
No, ma'am. It was
Doppler?
not done. No, ma'am.
Doppler was not done. Can it give us a clue?
Yeah, ma'am. That vascularity will be impaired.
Yeah. So that can give us a clue, no?
Yes, ma'am.
And then what about the MRI, this thing? In your case?
No, ma'am. We didn't get an MRI.
Ah.
We did diagnostic laparoscopy. Actually, we first planned for diagnostic laparoscopy with self-injection, ma'am. Then
Yeah, that's a
intraoperatively, we found out it was torsion.
Yeah. So what do you think is the cause in your case?
Because of that hematosalpinx, that fallopian tube torsion.
No, it's a sterilization done. So length is also shortened.
Ma'am.
And then, yeah, what could be the cause in your case?
Sorry to interrupt, ma'am. Time is up, ma'am.
No, we have to ask questions to give mark now. So how do you decide, ma? At least 2 questions we should ask, no? There, the projection time is getting delayed. Yeah, at least 2 questions. Give us time.
Okay, ma'am. No problem, ma'am.
No problem.
The Doppler is not done. That's okay. Then MRI not done. Then what could be the cause? You have done a laparoscopy and you know. Can you tell me what could be the cause in your case?
Pelvic
Gold
inflammatory.
standard is diagnostic lab and therapeutic simultaneous. I agree with that. Can you guess the cause? Okay, no problem.
Pelvic inflammatory disease, ma'am. PID.
Sterilization you have given. Okay, pa. Thank you. Next candidate.
Dr. CJ Andrews.
The coordinator, the time is getting delayed in projection of the next candidate. Please avoid that. We will get 1 minute.
Dr. CJ Andrews.
Yes, ma'am. Good morning, ma'am.
Yeah, come on, present your case, ma.
Good morning, ma'am. I'm presenting a case of twin-to-twin transfusion syndrome with IUD of both fetus and obstetric catastrophe. Introduction: twin-to-twin transfusion syndrome is a rare but serious complication of monochorionic twin pregnancy. It is characterized by the development of abnormal placental vascular communication from one fetus to the other fetus. If left untreated, it leads to high rates of perinatal morbidity and mortality due to its poorly understood etiology and difficulty in diagnosis and treatment. Presenting a case of a 24-year-old primigravida who came to our hospital at 31 weeks, 1 day period of gestation with monochorionic diamniotic twin gestation with complaints of absent fetal movement since 1 day. She had conceived spontaneously and taken her antenatal checkups in AJMS. First trimester scan was done at 9 weeks period of gestation, showing a twin gestation with 2 yolk sac and 2 cardiac activity was seen. Anomaly scan was done at 20 weeks of gestation, twin gestation at 20 to 21 weeks with fundoposterior placenta with no fetal anomalies. Later, the patient did not have regular follow-up. On examination, moderately built and nourished, cooperative and well-oriented, vital stable, systemic examination, CVS and RS clinically normal. Per abdomen examination, longitudinal lie, uterus 32 correspond to 32 week size, relaxed, multiple fetal parts felt, FHS 1 absent and FHS 2 absent, PV os closed. Management, induction of labor was done and extracted both fetus by vaginal delivery. Twin A, dead male, 44 grams, anemic, and twin B, a dead male, 1.1 kg, edematous. A single placenta with 2 umbilical cords were seen. The discussion: the diagnosis of twin-to-twin transfusion syndrome requires 2 criteria: presence of a monochorionic diamniotic pregnancy, presence of oligohydramnios, single deep pocket less than 2 centimeter in one sac, and polyhydramnios more than 8 centimeter in other sac. Screening for twin-to-twin transfusion syndrome should be done by ultrasound from 16 weeks onwards at 2-weekly interval by noting fetal biometry and deepest vertical pocket. At diagnosis, twin-to-twin transfusion syndrome should be staged using the Quintero system. Stage 1, twin-to-twin transfusion syndrome, more than 75% cases regress with perinatal survival of 86%. Advanced twin-to-twin transfusion syndrome, which is stage more than 3, has a perinatal loss rate of 70 to 100%. Treatment with fetoscopic laser ablation before 26 weeks can be done. Amnioreduction and septostomy can be done after 26 weeks of gestation. Even laser-treated twin-to-twin transfusion syndrome has perinatal mortality rate of 30 to 50%, 5 to 20% chance of long-term neurological problems. Conclusion, close surveillance of monochorionic diamniotic twins is important for early diagnosis and intervention for a better perinatal outcome. My reference is Williams textbook and areas high-risk pregnancy, and I'm Donald Safe. Thank you, ma'am.
Dr.
One question
Suji?
to you.
Yes, ma'am.
In your counseling outcome, what will you advise when you get such a case? You will, because the outcome is very poor.
Yes, ma'am.
And what will be your advice when you see her at 16 weeks?
Ma'am, we will explain regarding the condition, ma'am, of the patient, and after doing a scan, after confirming, we will.
No, all that is confirmed. Your communication, your advice at 16 weeks. You know, that much is the neurological outcome, long term, and the perinatal outcome, all that you will explain.
Yes, ma'am.
And then anything else?
Ma'am, is it before IUD, ma'am, diagnosing, or I didn't
No,
get
16 weeks. 16 weeks.
Ma'am, regular follow-up we will advise, ma'am, with a regular scan, follow-up scan with fetal biometry and the growth of the fetus.
No, with all that, with all that, mortality is high and long-term neurological deficit is there.
Yes, ma'am.
So what about the option for a termination?
Ma'am, expectant management, ma'am, amnio reduction.
Okay, ma'am, you can ask one question.
Dr. Siji, you said from 16 weeks we will monitor for TTTS.
Yes, ma'am.
Any other clues even earlier than 16 weeks you can get by ultrasound? For to expect a TTTS in the future, this pregnancy might develop. Will you get any clues? When? How? Any ultrasound clues you will get earlier on, even before 16 weeks, that this pregnancy might end up in a TTTS?
Fetal anemia and one baby.
Ma'am, discordance in growth, ma'am, and one baby is,
yes.
One is anemic and one is we can counsel at the early.
No, not before 16 weeks. I'm saying when it's before 16 weeks, what is the clue? Fetal anemia develops later. Before 16 weeks, what is the clue you can get that this pregnancy might develop a TTTS?
Placenta, ma'am?
No. In the baby. When you do an ultrasound for the babies, any clue you will get? Okay, there will be disparity of the nuchal translucency. So that will give you a clue that a TTTS will develop later on. Okay, thank you.
Thank you, ma'am.
Next candidate, Dr. Sonam. Dr. Sonam. Dr. Sonam, please respond. Dr. Sonam, you're there? Dr. Sonam. Dr. Sonam, kindly respond or we'll move on to next person. Dr. Soumya Ravindran. Dr. Soumya Ravindran.
Good morning, ma'am. May I share my screen?
Yeah, share your PPT and status.
Ma'am, I sent you this file. Can you share it, please? I want.
Share your PPT, Dr.
Oh, yes,
Soumya.
ma'am, I shared it in chat.
No. Share it on the share screen.
Oh, okay. Is my screen visible, ma'am?
No.
Dr. Soumya.
Yes, ma'am. I couldn't share my screen, but I shared it in chat box. Can you please help me share it?
Okay, we'll coordinate it. Next candidate, Dr. Shruti. Sonam, are you ready?
Yeah, ma'am.
Yeah, share your
ma'am. Yeah, ma'am. I'm sharing. Ma'am, it's not working. Ma'am, it's visible?
Dr. Sonam, no, it's not visible.
Dr. Sonam, no. Now, ma'am.
Dr. Sonam?
Yeah, ma'am.
Your slide is not visible. Kindly share it.
Yeah, ma'am. It's visible now, ma'am?
Yeah. Start presenting.
I'm presenting a rare case report of successful bicornuate uterus pregnancy in one horn and uterine perforation in other horn. Introduction: a bicornuate uterus is a uterine malformation that is produced due to impairment in fusion of Mullerian depth. This condition may be diagnosed in pregnancy or before. It is a rare anomaly, but it is associated with worse reproductive outcomes. Recurrent pregnancy loss like 15 to 27%, preterm labor 4%, fetal growth retardation. The incidence of bicornuate uterus is reported to be 10.3% in women. Case report: a 28-year-old female patient G2A1.
Listen பண்ணிருக்காங்க நிறைய ப்ராப்ளம்ஸ் இருக்கு போல இருக்கு. டக்கு ஸ்கிரீனுக்கு வர மாட்டேங்கிறாங்க.
ஆமாங்க இப்பதான் 4 பேரை பிடிச்சிருக்காங்க. எனக்கு என்ன 15 கிட்ட இருக்காங்க. எனக்கு கொடுத்துருந்ததுல 10:50. அவங்க ஆரம்பிச்சது half an hour லேட்டு. எப்படி 11:30.
With 33 weeks of pregnancy, presenting in OPD with complaint of abdomen pain and leaking PV since 12 hours. On examination, general condition was fair. Per abdomen uterus acting moderately. For vaginal examination, cervix 1 centimeter started effacing membrane absent like a clear headed brim. Investigation, all investigation were done, which was normal. Management emergency analysis was done in view of PPRM. Intraoperative finding were incidental uterus with non-communicating bone and right. A male child 2.05 kg was delivered, and there was perforation. Post-operative course was uneventful. Congenital malformation are relatively common and asymptomatic. Uterine anomalies are associated with an increase in malpresentation, premature labor, abnormal presentation with depression, necessity of cesarean section. Biconate uterus does not and may carry a pregnancy to term. It is necessary to establish a prenatal diagnosis to ensure proper care and prevent complications. Conclusion: pregnancy is a biconate uterus, deserves early diagnosis of anomaly, meticulous care in pregnancy and delivery to avoid the associated adverse outcome. Successful outcome could be achieved with biconate uterus. Thank you, ma'am.
Dr. Sonam, which is the best time to diagnose a uterine anomaly?
Ma'am, when patient comes or with ANC visit.
So which is the best time you can diagnose a uterine anomaly, and what method is the best method to diagnose a uterine anomaly?
Ma'am, ultrasonography.
Okay. Plain ultrasonography is the best method? Plain ultrasonography or any other technique?
Ma'am, hysteroscopy and laparoscopy.
No. Ultrasonography. No. Ultrasonography. What ultrasonography?
Yeah. Ma'am, plain sonography.
Not plain. What technique in ultrasound is the best to diagnose a uterine anomaly? What we do is that normally we do a 2D ultrasonogram.
Yes, ma'am.
So which is the best method to do? Yes.
Ma'am, 3D?
Yes, we should do a 3D ultrasound to diagnose a uterine anomaly.
First trimester.
Okay.
The ideal time is inter-pregnancy interval. Even before pregnancy, it's the best time to diagnose a uterine anomaly. Apart from 3D ultrasound, what is the other gold standard method to diagnose? For example, it's also associated with vaginal septum. Then MRI is the best method to diagnose an ultrasound uterine anomaly.
Next.
Now for this biconate uterus, you've already identified. Will you put a encerclage?
No, ma'am, we couldn't identify. Actually, patient presented at 33 weeks and with labor pain.
If a pre-pregnancy patient comes with a biconate uterus and she's booked with you from first, will you put your cervical encerclage?
Ma'am, for prevention of labor, we can put it.
You will put it. Yes, Dr. Sonam, will you place an encerclage or you will just monitor her?
No idea, ma'am.
Okay. Whether this perforation could have been avoided? If so, how?
Yes, ma'am.
Whether the perforation could be avoided, and if so, how? I think we can go to the next candidate.
Next candidate,
Lavanya, Lavanya, next presenter.
Dr. Shruti, yes. Dr. Shruti, yes.
Yes, ma'am. Present, ma'am.
Yeah, kindly share your PPT and start presenting.
Okay, ma'am. Ma'am, someone else is projecting their screen, so I can't share mine. Ma'am, is my screen visible, ma'am?
Yeah, start, Shruti.
Okay, ma'am. Good morning, ma'am. My case is a rare case of severe cholangitis with biliary sepsis complicating pregnancy. Acute cholangitis, also known as ascending cholangitis, is a serious disorder of the biliary system which can be life-threatening if left untreated. The most frequent reason of this acute cholangitis can be obstruction of the bile or hepatic ducts, that is choledocholithiasis, stone in the bile duct or the hepatic duct, and other causes like primary biliary cholangitis and primary sclerosing cholangitis. They have autoimmune etiology. So the objective of my study is that we deal with a case of severe cholangitis with biliary sepsis complicating pregnancy and its outcomes, so that we have to know about how prompt diagnosis and appropriate intervention at timely diagnosis can save the patient, and to know about the new treatment modalities available. So in our case, a Gravida 3 paravan live 1 abortion 1, a previous LSCS at 31 weeks gestational age, was referred to us with frequent episodes of fever, abdominal pain, and vomiting. And on evaluation, she had hemolytic anemia with jaundice. She had bilateral subconjunctival hemorrhage and also high colored urine. So first of all, we had suspected about infectious causes like leptospirosis and all, and we have ruled out that. Lepto-IgM and all were negative, and on examination she had tachycardia, tachypnea, fever with temperature of 102 Fahrenheit. ICPRES was present, and uterus was corresponding to 30 weeks with active fetal heart rate. And in per speculum examination, the vulva, vagina were healthy and no abnormal or foul-smelling discharge, thereby ruling out some local causes for infection. And on per vaginum, cervix was uneffaced, was flatulous, and no shown, no draining. The patient was admitted, and patient was admitted and evaluated, and she was connected to CPAP due to respiratory distress. Her SpO2 was not maintaining in the room air, and on evaluation, the liver function test showed elevated liver enzymes, giving a picture of hepatitis, and total bilirubin was also elevated up to 3.1, and total count was elevated. Then we had imaging modalities with the USG abdomen and CECT abdomen, which showed features of severe cholangitis with evidence of cholelithiasis. This was her ultrasound abdomen taken, which showed a dilatation of the bile duct. And patient went, because due to this infection, patient went into preterm premature rupture of membranes and was delivered by VBAC. A male baby of 700 grams, and we couldn't save the baby because of severe respiratory distress syndrome and extremely preterm and extremely low birth weight. And soon after the delivery, she became symptomatically better on with CPAP with FiO2 minimized. Blood culture report showed Klebsiella species, and once the infection was settled down, we planned her for biliary stenting with the ERCP, endoscopic retrograde cholangiopancreatography, and she recovered completely. Culture sensitive antibiotics and other supportive treatments were also given. And,
sorry to interrupt, ma'am. It's time for discussion.
Okay, ma'am.
Shruti, thank you. Nice case.
Yes,
was it CT did you do during pregnancy? In your case?
Yes, ma'am. USG abdomen was taken while she was pregnant, ma'am. And only after VBAC, we have gone for a CECT, ma'am.
After that?
For confirmation of the diagnosis, ma'am.
Okay. I was under the impression that it was done during antenatal.
I have written it like that, ma'am. Sorry for the confusion, ma'am.
So it is, okay. Generally, you don't do, right?
Yes, ma'am.
Right. So that acute cholangitis, was there any stones noted?
Yes, ma'am. Gallbladder stones were present.
Have you mentioned about it, the gallstones?
No, ma'am. In the imaging, but we were visualized the dilatation of bile duct only, ma'am.
So you could have done an MRI, right?
Yes, ma'am.
During antenatal period itself.
Since the patient was on CPAP and we couldn't
Yeah,
we
belly
couldn't
condition was
shift
not
her for.
treated.
Yes, ma'am. That's fine.
Okay, ma'am, any question for you?
No, madam. Nice presentation.
Yeah.
Thank you.
Thank you, ma'am. Next, Dr. Soumya. Dr. Soumya. Dr. Soumya. Dr.
Is my
Soumya?
screen visible, ma'am?
Yeah.
Good morning, everyone. This is Dr. Soumya, postgraduate government Dharmaburi Medical College. My topic is heterotopic pregnancy. It's defined as the simultaneous presence of intrauterine and ectopic pregnancy. The natural incidence is 1 per 30,000 pregnancies, and with artificial reproductive techniques, it is 9 in 10,000 pregnancies. Isolated ectopic pregnancy is on average 1 in 150 live births. A known pre-existing intrauterine pregnancy can be falsely reassuring and can delay the diagnosis of a potentially life-threatening concurrent ectopic pregnancy. The risk factors for ectopic or artificial reproductive techniques: prior ectopic, prior tubal surgery, use of an intrauterine device, and smoking. Those patients are more likely to have spontaneous or medically induced abortions and are 30% less likely to have live birth delivery. And the history is, my patient is a 35-year-old female, gravida 5 para4 lipo, previous normal vaginal delivery, came with 2 months of amenorrhea with complaints of abdominal pain, vomiting, and giddiness. She's a known case of bronchial asthma for 5 years on treatment. Vitals for temperature was normal, BP was 90/60, and pulse rate was 120 per minute, and SpO2 was 98% at room air. She was conscious, oriented, afebrile, not dyspneic, not tachypneic, pallor was pleasant, and no pedal edema. CVS RS was no abnormality detected, and per abdomen distension was there, tenderness was there, and per vaginal examination showed cervical motion tenderness, and there was no bleeding pain. Investigation: CBC was HB 6.7 gram, and the renal and liver parameters were found to be normal. Ultrasound abdomen and pelvis done revealed a single intrauterine gestation of 7 weeks gestation. Cardiac activity was not seen. Right ovary was normal. Left ovary was not visualized. Moderate hemoperitoneum was seen. Complex heteroechoic lesion in pelvis with moderate hemoperitoneum. So we took her up for emergency laparotomy. Intraoperatively, we saw 500 ml of hemoperitoneum and 750 gram of clots. There was an evidence of ruptured ectopic pregnancy in left fallopian tube cornual end, and left side partial salpingectomy and right side fimbrectomy was done. And manual vacuum aspiration is done for missed abortion. 1 PRBC and 4 FFP transfused intraoperatively. IV antibiotics were given, and post-operatively, in view of anemia, 1 PRBC was transfused. In conclusion, heterotopic pregnancy is an extremely rare finding, even in those patients with risk factors. While the presence of risk factors can help diagnose an heterotopic pregnancy, it should always be considered in all pregnant patients with abdominal pain. An intrauterine pregnancy does not exclude an ectopic pregnancy. This case highlights the necessity to consider heterotopic pregnancy as a differential diagnosis of internal hemorrhage even in low-risk patients. Thank you. Hello, ma'am.
Yes, thank you, Pa. So she had almost a twin pregnancy, one heterotopic, one intrauterine.
Yes, ma'am.
What are her risk factors for a twin pregnancy?
For an ectopic pregnancy, there must be an artificial reproductive technique or a prior.
No. Your patient's risk for developing, having a twin pregnancy.
Ma'am, actually, in my case, there is no risk factor for developing an ectopic pregnancy. She's a gravida 5 para4 lipo patient. Previous all normal.
No, for developing a twin pregnancy. I'm not saying ectopic or heterotopic. What are the risk factors in your patient for development of a twin pregnancy?
She's a multiple, but there is no risk for twin pregnancy.
As the parity increases, as the age increases,
age and parity itself is a factor to suspect.
Okay, ma'am. Sorry.
She's already 3-5. Yeah. Don't say no risk factor.
Okay.
Her age and parity itself is a risk factor. Okay. And then family history, if at all.
For example, intrauterine pregnancy has been a live pregnancy in your patient.
I would have asked.
Yes, how would you have managed?
Since the family is complete, I would have advised her for sterilization, the same procedure, because this ectopic will lead to future ectopic. So since the family is complete, I would have advised her. Even in spite of that, if she was not willing, then I would have asked her like I would have tried for a salpingostomy or a salpingotomy or a partial salpingectomy on one side, and I would have left the right side alone so that she can conceive in future.
No. What I'm asking is, in this condition, if the pregnancy which is intrauterine had been a live one, here the FH was absent, you did a manual vacuum aspiration. If this baby had been a live baby, how different would have been your management?
I would have done a salpingostomy or a salpingotomy only for that ruptured ectopic. I would have left the intrauterine alone. I would have explained that the chances of abortion is more for this. Even though it is viable now, it may not be viable because we are opening her up. We are doing a laparotomy. So I would have explained her all the risks, and then I would have gone for a salpingostomy or a salpingotomy.
Okay. Thank you.
Your case is ruptured, Soumya. So your treatment is salpingostomy in a ruptured ectopic, fallopian tube rupture.
No, ma'am.
What is the treatment in unruptured and ruptured? It is already ruptured. So your treatment should be?
The same emergency laparotomy with
no
salpingectomy.
I would
it's
not.
Already
I would not have
ruptured.
done a MBA.
No. There is no role for salpingostomy.
MBA.
Okay, ma.
For this.
Next.
Next candidate, Dr. Subhashri.
Ma'am, yes, ma'am.
Share your PPT and start presenting.
Ma'am, Soumya is sharing her screen, ma'am, so that I can't.
Sharing your PPT. Is this Dr. Subhashri? Yes.
Yes, ma'am.
Other person, the Dr. Subhashri is not here.
Ma'am, I'm Dr. S. Subhashri, ma'am. Subhashri, yes.
Okay, start.
Is my screen visible, ma'am?
Yes, ma'am. Start.
Okay, ma'am. Good morning, ma'am. I'm Dr. S. Subhashri from JMKMC Salem. My topic is on bladder injury following a normal delivery, a very rare case report. Introduction. Bladder rupture following normal delivery is a very rare condition of less than 1% of incidence. Increased intravesical pressure and weakening of the bladder are the chief predisposing causes for bladder rupture. This complication represents a surgical emergency, and a rapid diagnosis represents a challenging for gynecologists. Surgery is crucial for the resolution of this, consists of urine removal from the peritoneal cavity and repair of the bladder. Case report. Mrs. X, 23 years old, para 1 living 1, normal delivery at a PHC. She presented on postnatal day 2 with chief complaints of abdomen distension and abdomen pain, not able to pass stools, reduced urine output for 1 day. No history of hematuria, voiding difficulties, abdomen trauma, fever, chills, vomiting, and no history of previous surgery, any other comorbidities, and her past history is insignificant. On examination, her BP is 160 millimeters of mercury and pulse rate is 120 beats per minute. Systemic examination normal. Per abdomen examination, there is a mild abdomen distension present with diffuse tenderness, no guarding rigidity. Uterus is firm and contracted. Bowel sounds present. Per vaginal examination, episiotomy wound is intact, no bleeding PV. Her urine output is 30 ml per hour. Her investigations showed a slight higher end of total count 23,200. Her hemoglobin is 9.9 grams. PCV is 28. Blood urea is 36 milligrams per deciliter, and serum creatinine is 1.6. Her ultrasound showed mild to moderate free fluid with a dilated bowel loops present. CECT abdomen showed moderate free fluid, dilated gas bowel of 4.2 centimeters. Hence, we planned for laparotomy. Intraoperatively, 1.5 liters of turbid fluid in the abdomen. Entire gastrointestinal tract was traced to be normal. Surprisingly, there was an intraperitoneal bladder rupture posterior wall of the bladder thinned out and necrosed, which we proceeded to excision of the necrosis and double layer closure with intraperitoneal drain, pre-vesical drain, and suprapubic catheter was kept. Discussion. In comparison with cesarean section, normal delivery rarely reached to a bladder injury. In 1995, Kibble was the first one to reported this bladder injury following normal delivery for the first time. Unsatisfactory bladder emptying antenatally, prolonged labor and incomplete bladder emptying during labor can build the pressure in the bladder. Furthermore, the descent of the head during contractions can lead to the rupture of the bladder. Symptoms like inability to empty bladder, hematuria, anuria, suprapubic pain, urinary retention are present in bladder rupture. But my case presented in an unusual way without any typical symptoms. Since the patient had reduced urine output, abdomen distension not settled, we proceeded for laparotomy. There is rapid urine absorption from peritoneal cavity to plasma, thereby maintaining equilibrium between the two. Studies have shown that serum urea and creatinine to be elevated in 45% of patients who present within 24 hours of bladder rupture and nearly 100% for those who present after 24 hours. So we must conclude that suspecting a bladder injury in cases who present with urological and abdomen symptoms, eliciting the voiding history and monitoring output and the serum urea creatinine levels in women with ascites and peritonitis. Thank you, ma'am.
So, Dr. Shubhashri, it's a very nice case. You have said the importance of bladder emptying frequently during the intrapartum period, maintaining input-output chart during the intrapartum and also the immediate postpartum period.
Yes, ma'am.
So this is very, very vital. Though it looks trivial, it is very, very vital, even in a normal delivery. So how was the diagnosis made in your case? By directly CECP or an ultrasound was done?
Ultrasound was done, ma'am. There was a mild to moderate free fluid with dilated bowel loops, but the bladder rupture was not diagnosed in the imaging, ma'am. It was intraoperative finding only. Since the patient was signs were in worsening, we planned for laparotomy, ma'am.
Okay, you proceeded earlier.
Yes, ma'am.
Oh, thank you.
Thank you, ma'am.
Next candidate, Dr. Sudarshana Devi R. Dr. Sudarshana Devi R.
Yes, ma'am. You're able to hear me, ma'am?
Yeah. Share your PPT.
Good morning, ma'am. Myself, Dr. Hello. Are you able to hear me, ma'am?
Yes, pa.
Screen is visible, ma'am.
It is visible.
Good morning to everybody. I am Dr. Sudeshna from Saptagiri Medical College, Bangalore. Today, I want to present a rare case regarding coagulative necrosis in a leiomyoma. Coming to introduction, coagulative tumor necrosis or tumor cell necrosis occurs in approximately 80% of leiomyosarcomas, but it is rare in benign uterine leiomyomas. This type of necrosis is characterized by an abrupt transition from a viable to necrotic cells without intervening zone of reparative connective tissue reaction. Coming to case report, a 22-year-old P1L1 presented with a complaints of heavy menstrual bleeding since 2 years. Her cycles are regular with patches of large clots and congested dysmenorrhea. She was diagnosed with fibroid uterus 2 years back and underwent cesarean section for the same. Significant history included intake of tablet tranexamic acid on and off in the last 2 years. Further examination revealed the uterus is of 12 to 14 week size. Radiology ultrasound showed solitary anterior wall subserosal fibroid of 4.2 into 3.4 into 4.4 centimeters with cystic changes. As she was symptomatic, she underwent open myomectomy. The cut section of myoma showed a cheesy caseous degenerative material oozing out from the center. Histopathology suggests of leiomyoma with coagulative necrosis along with hyaline and fatty degeneration. Come to the discussion part. In a benign lesion, the drug history should be reviewed so that this type of rarely unhealing impact type of necrosis is considered as an underlying cause of an apparent coagulative necrosis, so that preventing from the prolonged follow-up and unnecessary further surgical intervention. Come to conclusion, coagulative necrosis is usually seen in malignant tumors, but in this case, it was observed in a benign glioma, possibly secondary to prolonged and repetitive use of tranexamic acid, and so presented this case as of its rarity. Thank you.
So how long this tranexamic acid was used?
Ma'am, the patient was telling for 2 years she was taking on and off for every month or every second month she was taking the tranexamic acid, ma'am. And there is no documentation of how much dose and how many months she has taken. As said by the patient history, it has been taken for 2 years.
Okay. So, did you find any literature saying that?
Yes, ma'am. Yes, ma'am. Yes, ma'am. We have I researched 2 articles showed there is a incidence of this taken a study of 145 patients and in one study and 200 patients in second study. They found that around 60 people were shown with the same findings of this coagulative type of necrosis of on and off use of tranexamic acid.
Any dose related, pa?
Ma'am, they didn't mention any dose, ma'am, because one patient was taking 500 mg, one person was taking IV injection of 1000 grams. So they didn't mention the particular dose regarding, but they made of duration of more than 6 months or more than 1 year of continuous uses. There were the reported cases of this type of necrosis in benign tumor, ma'am.
So you have coagulative necrosis in fibroids other than where tranexamic acid was used?
Usually it is seen in malignant type of like leiomyoma sarcoma or malignant cases. There will be usually cases of reporting coagulative necrosis, ma'am. But it is the patient is young lady and she just presented with a leiomyoma of subseries of fibroid. But the patient in histopathological finding it came out as to be a coagulative necrosis, ma'am.
Okay. Thank you, Sudeshna.
Sorry, ma'am.
Yeah, thank you. Madam, you have any questions, madam?
No, actually, I couldn't listen to it. My audio got cut. So maybe next candidate.
Is it okay, ma'am? Thank you, ma'am.
Thank you.
I didn't listen to her. Okay. Thank you.
Candidate Dr. Sukuru Vasuda. Dr. Sukuru Vasuda.
Hello. Are you audible, ma'am?
Yes, Sukuru Vasuda. Yes, ma'am.
Yes. Madam, just 2 minutes, ma'am. We are sharing our screen.
Yeah.
Some other are sharing their screen, so we are unable to do.
We should pay now.
Dr. Sudeshna Devi, please stop sharing. Dr. Sudeshna Devi, please stop sharing.
On phone, but the class.
Dr. Sukuru Vasuda.
Yes, ma'am. We are sharing. Just a second. Okay. Ma'am, it's there in chat box. Can you please share?
You can't share it there?
We are unable to. Can you please?
Okay, we'll call you next.
Okay.
Next candidate, Dr. Supriya CJ. Dr. Supriya CJ. Dr. Supriya CJ. Dr. Supriya CJ.
Yes, ma'am.
Kavita, no share screen share.
Sharing PPT and office.
Okay. Is it visible, ma'am?
Madam, share actually.
Hello.
Yeah, it's visible, pa.
Good morning,
Yes,
everyone.
start presenting.
Yes, ma'am. Good morning, everyone. Today my presentation is on AML, case of AML, which is Introduction. As we all know that AML accounts for about more than 2/3 of leukemias during pregnancy, and due to the overlapping symptoms of pregnancy like fatigue, shortness of breath, or physiological alteration of peripheral counts, it might delay the diagnosis and therapy. As a known complications, abortion, premature delivery, IUGR, fetal and maternal deaths are possible. And due to the potential teratogenic risk, chemotherapy is not indicated in pregnancy. We had a patient who was 34-year-old, gravida to Paravan live one, 36 plus 6 weeks of gestation, who came with complaints of bleeding gums since 15 days. Her obstetric history, priorly she had delivered a full-term normal vaginal delivery of about 3 kg baby 3 years back, and currently her prior ANCs were uneventful in the present pregnancy. On examination, patient had pallor, oral cavity showed petechias, no active bleeding gums, and petechial rashes and ecchymotic patches all over her body and skin. Obstetrical examination was unremarkable, and there was no lymph nodes palpable. Investigations were CBC and blood picture was sent, which revealed anemia and the platelet of thrombocytopenia of around 7,000 platelet, and total counts were raised to around 77,500. Blood picture showed 88% of blast cells, which was suggestive of acute leukemia. Hence, hematologist consent was sought, and peripheral blood flow cytometry, peripheral blood cytogenetics, and NGS molecular panel was done, which was diagnostic of acute leukemia, acute myeloid leukemia, and the pictures as shared below. Plan of management was for induction of labor, as she had because she had a prior normal vaginal delivery. We mainly planned for induction of labor or emergency cesarean in cases of maternal indication. And blood and blood product transfusion, avoiding sepsis, bleeding manifestation, isolation, low dose chemo post delivery, and hypomethylating agent with hypomethylating agents. Before induction, she was transfused with 2 RDP, 1 PRBC, and 1 SDP. And with 2 gels of prostaglandins was induced, and trial for about 12 hours was given, during which she was transfused, covered with the 2 SDPs. In view of failed induction, unfavorable cervix, and considering the risk of intracranial bleeding during bearing down effects and all, she underwent emergency LSCS in view of in view of the same mentioned below, and she delivered a female baby of around 2.4 kgs. She also received SDPs and PRBCs, 2 SDP, 1 RDPs, and 1 platelets intraoperatively. Post-operative period, she developed a type 1 respiratory failure, and HRCT was done in view of that, and CT image is shared as below, and it revealed bilateral basal consolidations, for which she was hiked up with antibiotics, and antifungal cover was also given. This one drain and
interrupt, ma'am. Time for the discussion.
Okay.
Dr. Supriya, what was the hemoglobin when she came with failure at 36 weeks?
8.1, ma'am.
Okay. You took her up for emergency LSCS or elective LSCS?
Emergency LSCS, since she was already induced, ma'am. So we couldn't wait for a prolonged long time. As she was on continuous SDP coverage, we managed to maintain her platelets above 50,000 by giving her SDP cover.
No. You induced her, and what was the indication for emergency LSCS?
Ma'am, we gave her 2 doses of prostaglandin gel, and unfavorable cervix was more.
So your indication was failed induction.
Yeah, but we didn't want to give further trial because of all the risk factors associated now.
So when did she deliver? Long back?
4 months back, ma'am.
How is the patient now?
Patient is fine now, ma'am. She's doing well. She's on chemo right now. During her post-operatively only, she was on low dose. Now she's on regular doses of hypomethylating agents.
What anesthesia was given, doctor?
General anesthesia, ma'am.
General anesthesia. And she developed pneumonitis.
Yes, ma'am. Post-operatively, she developed respiratory failure, like
What was the induction delivery interval?
Induction and delivery interval is around 13 to 14 hours.
You gave 2 doses at 6 to 8 hours interval.
Sorry, ma'am.
No, you gave 2 doses of prostaglandin at 6 to 8 hours interval.
Yes, ma'am.
2 doses at around 6 hours interval. We gave her a trial, ma'am.
So what was the Bishop score to decide for section?
Sorry, ma'am. I'm not
What
able
was the
to.
Bishop score to decide for section? I feel a normal delivery could have avoided the anesthetic complication. No?
Ma'am, but her Bishop's score was very poor, ma'am. It was 3 in both the examinations, vaginal examination, and she was still 36 plus 6 weeks, and her cervix was unfavorable. Further trial giving would lead to a catastrophe.
It was a poor Bishop score.
Yes, ma'am.
And general anesthesia both added to the risk of pneumonitis or complication.
Yes, ma'am.
Okay. Next candidate.
Thank you.
Dr. Sukuru Vasudha. Dr. Sukuru Vasudha. Dr. Sukuru Vasudha. Dr. Tamilvani.
Hello. Hello, I shared my PPT. This is Dr. Vasudha.
Sukuru Vasudha.
Yeah.
Venkat sir. Sir, can you share this PPT?
Hi, ma'am. This is Shruti, colleague of Venkat. Dr. Vasudha, can you share it again? We lost it.
No, ma'am. She shared it again now. Just now.
Yeah. I cannot see anything in the chat box. So
I've shared it again just now.
Dr. Tamilvani. Dr. Tamilvani.
Yes, ma'am.
Start sharing your PPT.
No, try it.
Hello, ma'am. My screen is visible, ma'am.
No, your screen is not visible. Tamilvani, Dr. Tamilvani.
Ma'am.
Yes, now it's visible. Start presenting.
Myself, Dr. Tamilvani from Kanyakumari Government Medical College. Good morning, ma'am. My presentation is on a rare case report on scar ectopic gestation. Introduction. Scar ectopic gestation is the rarest form of ectopic pregnancy and has been increasingly diagnosed all over the world with a substantial increase in cesarean rates. It is the life-threatening form of abnormal implantation of embryo within the myometrium and the fibrous tissues in the previous scar on the uterus. The incidence of cesarean scar ectopic varies from 1 in 1,800 to 1 in 2,200 deliveries. Exact etiology remaining unknown. However, the most accepted theory is blastocyst invade into the myometrium through microscopic dehiscent tract. In the absence of previous uterine surgery, this can occur due to trauma in artificial reproduction techniques. Case report. A 28-year-old gravida to para 1 live 1 previous LSCS with LCB 3 years with 7 weeks gestation presented to AN casualty with complaints of lower abdominal pain and bleeding per vaginum for 3 days. The patient was done USG outside on the day 1 of pain abdomen, which revealed no evidence of intra or extra uterine GSAT with beta HCG of 16,789. The beta HCG after 48 hours on day 3 of pain abdomen was 26,639. The follow-up USG after 2 days revealed the features of LSCS scar ectopic pregnancy with mild hemoperitoneum. On examination, the patient had mild pallor, tachycardia present, BP of 90/60. On perabdomen, CVS RS examinations were found to be normal. Perabdomen examination, there was diffuse tenderness present. Pervaginal examination, uterus normal size, cervical motion tenderness present, and there was bleeding per vaginum. Patient was initially resuscitated with IV fluids and then taken up for emergency laparotomy under general anesthesia. Intra finding there was a hemoperitoneum of 200 ml with the fresh bleeding present. Uterus was 10 week size. Bladder was drawn up, covering the cesarean scar pregnancy. The bladder separated by short dissection and incision made over the cesarean scar. Blood and products of conception removed by suction evacuation. The weakened cesarean scar excised from the lower uterine segment and the uterine incision closed in double layers. The post-op period was uneventful and the patient was discharged on post-operative day 5. Treatment depends on the gestational age, hemodynamic stability and availability of endoscopy, and further fertility and feasibility of serial USG follow-up. In the stable cases with absent fetal cardiac activity, methotrexate can be administered. USG guided potassium chloride can also be tried. There should remain a high clinical suspicion for C-scar ectopic in patient with history of cesarean deliveries presenting with first trimester bleeding. Thank you.
Doctor, my question to you, have we delayed the diagnosis? If so, what intervention you could have done early? Typical.
The patient presented to us with on day 3, ma'am. If we diagnosed early, we can have tried medical methods, ma'am.
How it was missed early, I asked question.
Or laparoscopic.
Ultrasound done, no intrauterine fetus noticed, whereas the beta HCG was high, right?
Yes, ma'am.
Have we delayed?
Yes, ma'am.
You could have done anything to diagnose early? Before rupture, you could have diagnosed.
Yes, ma'am. On first day itself, but on the first day there was no intra or extra uterine desat, ma'am, on ultrasound.
But that is the typical of ectopic, no?
Yes, ma'am.
What was the beta HCG on day 1?
On 16,789.
So obviously it is an ectopic, right?
Yes, ma'am. But the patient was initially treated outside, ma'am.
Right. Patient is presented with a typical history of ectopic. Beta HCG was high, and obviously there was a negative scan. What should have been done instead of delaying it?
Patient who should have taken up for emergency laparotomy.
MRI.
MRI can be done. Yes, ma'am.
So before rupture, you could have diagnosed. It could have given a clear picture about the scar endometriosis, right?
Yes, ma'am.
Okay, ma'am, you can ask.
What is isthmocele? Tamilvani? Yeah.
Yes,
What is isthmocele? Something connected with this.
Cervical.
Isthmocele. The name even says.
Previous. Previously thickened LC.
Sorry to interrupt, ma'am. Time up.
Okay then. Thank you.
Ma'am?
Yeah, thank you. But thank you. Just go and read.
Okay.
Dr. Suguru Asta. Shruti, ma'am, ready with the PPT, ma'am?
Somebody sharing screen. Hello.
Dr. Tamilvani, stop sharing. Okay, moving on to Dr. Tota Kavita. Dr. Tota Kavita.
Good morning, ma'am.
Share your PPT and start presenting, ma'am.
I'm presenting, ma'am. 1 minute, ma'am.
65.
Dr. Tota Kavita.
Yes, ma'am. Sharing, ma'am. 1 second, ma'am, please. I shared in chat box, ma'am.
You should share in the main page. Share screen is up. Here.
Hello. Hello.
Yeah, it's getting shared. It's getting shared.
This is Dr. Suguru Vasudha. Okay.
Yeah,
Dr.
yeah.
Suguru
Can I
Vasudha.
present?
Yeah, start presenting, ma'am.
Yeah, can I present? Okay, thank you. Good morning, everyone. This is Dr. Vasudha from Sri Venkateshwara Medical College, Tirupati. And I'm host today I do a rare case report on rudimentary horn pregnancy. Introduction. Rudimentary uterine horn results from incomplete embryological development of one of the two Mullerian duct systems. In general population, the incidence of rudimentary horn pregnancy in rudimentary horn varies from 1 in 1 lakh to 1 in 1,40,000. More than 500 cases of rudimentary horn pregnancy were reported so far. Diagnosis of ectopic pregnancy in rudimentary horn is difficult, especially in women with prior vaginal delivery. The natural course of such pregnancy varies from first or mid second trimester ruptures. Here I report a case of ectopic pregnancy in urinary horn of unicornuate uterus at the gestational age of 14 weeks. Case report is she's a 35 years female, came to the emergency with the complaints of severe lower abdominal pain, more on right side since 2 days. She is a para 2 live 2 woman. History revealed 4 months of amenorrhea and she is not uvectomized. Her 2 prior deliveries were full-term institutional normal vaginal deliveries. Her vitals were temperature is 98.7 degrees Fahrenheit, pulse rate was 116 per minute, blood pressure is 100 by 60 mm of Hg. On parabdominal examination, uterus corresponds to the size of 16 weeks. Tenderness is present in the hypogastric and right iliac fossa. Perspectival examination was normal. Bimanual examination reveals uterus corresponds to 16 weeks with right fornical tenderness. Urine pregnancy test was positive. Paracentesis was done and there was no hemoperitoneum. Ultrasound was done, which showed a curved elongated uterus with tapering of fundal segment. Rudimentary horn noted with endometrial cavity communicating with other horn. A single live intrauterine gestation noted in the endometrial cavity of rudimentary horn with 14 weeks of gestational age. He was investigated and emergency laparotomy was done, which revealed ectopic pregnancy in the rudimentary horn, and incision is given over the rudimentary horn and an alive fetus of 220 grams delivered. Placenta noted in the rudimentary horn and removed. Rudimentary horn excised and bilateral pubectomy was done. In the pictures, you can see the rudimentary horn, which is labeled with red arrow, and the blue one is the uterus. In the second picture, you can see the green one, which is the incision, which is the head of the fetus after giving the incision. And in the third photo, you can see the yellow arrow, which points towards the fetus, which is delivered. Discussion: women with a unicornuate uterus associated with rudimentary horn may experience various pregnancy and non-pregnancy related complications, including endometriosis, hematometra, infertility, recurrent miscarriages, uterine rupture, and abnormally adherent placenta. Renal tract anomalies will also occur in 38% of such cases due to thin and poorly developed myometrium. Most rudimentary horn pregnancies rupture between 10 to 20 weeks of gestational age. Therefore, once diagnosed with such pregnancy, includes the excision of rudimentary horn along with ipsilateral fallopian tube to prevent future ectopic pregnancies. Planned removal of rudimentary horn is advised when those are diagnosed of pre-pregnancy in women who decide future pregnancy. Thank you, ma'am.
Why you did cultosynthesis? Present era, are we still doing that?
Madam, we thought of fractured ectopic.
Yes, you have an ultrasound to tell you the hemoperitoneum, even non-invasive, no? Is it required or unwanted? What do you feel?
Madam, an ultrasound could have been done, ma'am, prior to cultosynthesis.
No, we don't do a cultosynthesis. Now it is not required. One. Second, see what difficulty you will encounter when you do a resection of this rudimentary horn. Surgical problem. What should you anticipate? How do you take a concern? And you have assisted the case, right?
Yes, ma'am.
Yeah, tell me.
Madam, there will be closure in the after excision. There will be closure in the difficulty, madam. So there may be any chance to do hysterectomy, injury to the normal horn.
No. Ma'am, you can ask any question.
No questions, madam.
So this so you have assisted the case, you know how to go for a resection. Read about it. Thank you.
Okay, ma'am. Okay, thank you.
Thank you, ma'am. Next candidate, Dr. Tota Kavita.
Yes, ma'am. Presenting, ma'am.
Dr. Tota Kavita.
I'm sharing, ma'am.
Dr. Suguru, please stop sharing your PPT.
Okay.
Shruti ma'am, kindly help ma'am. Dr. Kavita, are you there?
Yes, ma'am.
We cannot open your PPT. It's like we need the permission to open. To download at least. Dr. Suguru Vasudha, please stop sharing.
Ma'am, actually we are sharing from same account, ma'am.
Okay, then we'll move on to next candidate, Dr. Sai Navya.
Okay.
Dr. Sai Navya.
Suguru's is not cleared, ma'am.
Dr. Sai Navya, you're there?
Yeah, ma'am, I was there, ma'am.
Start sharing, please.
Yes, ma'am.
நான் காலையில 2 மணி நேரம் அவங்க வெளில கூட்டிட்டு போயாச்சு. இப்ப இது 2 மணி நேரம். அவ்வளவுதான் என்னால முடியும். வெளில போகுது. அவளை வெயிட் பண்ண சொல்லி நான் இன்னும் ஒரு 5 கேண்டிடேட் நான் முடிச்சுட்டு வந்துருவேன். அங்க
Sai Navya.
11:30 பண்ணலாம் நான் வந்துருவேன்.
Hello, ma'am. Good morning, ma'am. Can I start my presentation, ma'am?
Please, yes. Go ahead. Yes, I start presenting.
Good morning, ma'am. It's a case of dilemmas in managing post-operative abdominal distension after cesarean section. A 26-year-old Srimati X, second gravida paravan live one with term gestation with 1 prior LSCS was admitted at teaching hospital on 21th October 5:53 p.m. posted for elective cesarean section in view of 1 prior LSCS with term gestation with cephalopelvic disproportion. At admission, her investigations found to be hemoglobin was 12.5 gram %, total count 9,400, platelet was 2,69,000, total serum bilirubin was 0.9, blood urea 35 milligram per deciliter, serum creatinine 0.9 milligram per deciliter. Lower segment cesarean section with bilateral tubectomy done under spinal anesthesia, delivered an alive female child of birth weight 2.6 kgs with Apgar 8 to 10, no intraoperative complications. On first postoperative day, patient has no complaints. As the bowel sounds were present, she was allowed oral sips. On day 2, patient developed abdominal distension, no vomiting, loose stools, no loose stools, no fever, no pain abdomen, no rigidity. On parabdomen examination, gaseous distension was present. Bowel sounds were absent. Uterus retracted well. On parvaginal examination, no active bleeding noted. And her investigations are also found to be normal. On X-ray abdomen and on erect X-ray abdomen, gas under the diaphragm was diagnosed along with distended bowel loops. Ultrasound abdomen shows dilated air-filled large bowel loops, small bowel collapsed, minimal pneumoperitoneum noted. To confirm that, we did a CT abdomen, showed dilated large bowel loops. Surgeon's opinion was taken regarding the case. They diagnosed it as intestinal obstruction secondary to inflammation and adynamic obstruction. The patient was managed conservatively on nil oral, IV fluids, Ryle's tube aspiration, IV antibiotics, ceftriaxone sulbactam, 1.5 gram IV BD. Bowel sounds appeared by 4th postoperative day, passed flatus on 5th postoperative day, repeat X-ray abdomen normal on 5th postoperative day. Suture removal was done on 7th postoperative day, discharged on 8th day. Discussion: gastrointestinal complications after cesarean section are paralytic ileus, which is the most common. Among these, paralytic ileus is the most common. Early postoperative bowel obstruction next to paralytic ileus, then followed by adhesions, Ogilvie syndrome, sigmoid volvulus. Usually, bowel sounds appear within 6 to 8 hours after surgery. After laparotomy, small bowel motility return within several hours. Gastric motility 24 to 48 hours. Colonic motility 48 to 72 hours. Paralytic ileus being the most common complication, it is a failure of transmission of peristaltic waves secondary to neuromuscular failure. Uremia and hypokalemia are also the most common contributory factors with paralytic ileus. Present with absent bowel sounds, no passage of flatus, abdominal distension, vomiting. Radiologically, abdomen shows gas-filled loops with multiple air fluid levels and managed by nil oral, Ryle's tube aspiration, electrolyte balance must be maintained. Abdominal girth should be measured to assess the progress. In case of intestinal obstruction, patient...
No, let her complete, ma. Yeah, complete.
In case of intestinal obstruction, patient presents with acute colicky abdomen, vomiting, distension, visible peristalsis may be present, high-pitched or vigorous bowel sounds. Radiologically, proximal to obstruction, dilated bowel with multiple air fluid levels, distal to obstruction, collapsed bowel. Managed by nil oral, Ryle's tube aspiration, fluid replacement, IV antibiotics, surgery if needed. Sigmoid volvulus is twist in the axis of loop of bowel, either clockwise or anti-clockwise, presents with pain abdomen, absolute constipation, that is obstipation, enormous distension of bowel, tire-like feel of abdomen is diagnostic of sigmoid volvulus. Radiologically, single grossly distended loop of colon arising out of pelvis extends towards the diaphragm, treated by colonic decompression. Adhesions present with pain abdomen, which is sharp, sudden colicky, episodic, radiologically
Now
dilated.
explain your case, ma. Conclude your case. Don't go into DD in detail. Conclude your case.
Cesarean section is the most common abdominal surgery performed worldwide. Abdominal distension is one of the complications after cesarean section. As there are many causative factors for post-cesarean abdominal distension, exact cause could be made out by keen monitoring, keeping paralytic ileus and Ogilvie syndrome high in the list of differential diagnosis. It can be managed by early anticipation, early ambulation, early oral nutrition, and early catheter removal, ma'am.
Ma'am?
Hello, ma'am.
Yeah. Ma'am, can you ask?
Yes,
your
ma'am.
question? Yeah.
Yes. Can intestinal obstruction happen during the antenatal period?
Yeah, ma'am, it can happen.
What are the causes? In your patient, what could be the cause if it happens in the antenatal period?
Post-cesarean adhesions, previous...
It's a, there might
it's a
be
case
a
of post-cesarean pregnancy, so we can answer. Adhesions might be the cause, ma'am.
How will you manage that condition? How will you manage if you are
Surgical.
directly? You will
Ma'am?
go for surgical.
No, ma'am. First, we should investigate the patient.
Okay.
Erect X-ray abdomen followed by CT. No, ma'am.
Antenatal checking will
X-ray and
take all
CT
those.
are contraindicated in
Antenatal.
antenatal period. Okay.
Antenatal, don't think about CT, dear.
Okay, ma'am. Sorry, ma'am.
So what investigation?
Ultrasound abdomen.
Yes, ultrasound can pick up
MRI
the,
can be taken.
yes, even ultrasound will pick up the dilated loops and even the collapsed loops, and so it will show the site. So directly will go for surgical management, or you will do conservative management?
First we can manage conservatively. Then, if patient will not get improved, then we can plan for surgery.
So delay can cause what? If your intervention is delayed in intestinal obstruction, what complication it can cause? To the small bowel.
Perforation, peritonitis.
Small bowel.
Perforation and peritonitis.
Gangrene also, no?
Oh, okay, ma'am. Gangrene.
Could there be an bowel, stomach perforation? In your case,
No, ma'am.
post-operatively, is there any possibility? It was, you
Bowel
said,
perforation.
but no, I'm asking about stomach. Could that be a DD? You talked about all obstructive lesions. Could that be a DD? I'm asking. Okay, ma'am.
Okay. Thank you.
Thank you.
Next candidate, Dr. Tota Kavita.
Tota Kavita, repeated calls not coming.
Ma'am, I'm sharing, ma'am. Sorry.
Dr. Navya, can you stop sharing your screen?
Yes, ma'am.
Dr. Kavita, are you there?
Yes, madam. Yes, ma'am.
So yeah.
Good morning, ma'am. I'm Tota Kavita from SV Medical College, Tirupati, madam. Today, my case is a primary amenorrhea with Miller duct anomalies with hypoplastic uterus, Mayer-Rokitansky-Kushner-Hauser syndrome, ma'am. Introduction. It is a form of Müllerian agenesis and is a cause of primary amenorrhea. It is mainly characterized by the absence of uterus, cervix, and upper vagina. 25% of the cases can have a short vaginal pouch. In these cases, secondary sexual characters will be normal, and their karyotype will be 46XX, and it occurs in 5,000, 1 in 5,000 to 1 in 20,000. In these cases, the ovaries will be normal as they are developed from the ovarian ridge, and this syndrome can be an isolated. That is a type 1. That is a more frequently isolated, and the type 2 is associated with the renal, vertebral, and cardiac defects. Vaginal aplasia, it is mainly treated by creating a new vagina. Counseling should be done to the patients and their family members. There is a possibility of conception by the donor oocyte and the surrogacy. In my case, the clinical presentation is a 17-year-old female came to an OPD with a complaint of not attaining her menarche. She is unmarried. On examination, her height is 150 centimeters and weight 48 kgs, and BMI is 21.3 kg per meter square. And in Tanner staging, her bilateral breast and the pubic hair were normal, and per abdomen examination, it is soft, and external genitalia is healthy, and per rectal examination, the uterus is not palpated. Clinical course, the patient had an investigations at 17 years age. In that, she had a normal hormonal studies, an ultrasound. The uterus is not visualized, but the bilateral ovaries were normal. CT abdomen and pelvis, in that uterus is not adequately visualized and the ovaries were normal. MRI pelvis, uterus is not visualized, a rudimentary thin structure of 1.8 into 0.3 centimeters with a no proper endometrial is observed. Mullerian duct anomaly with a severely hypoplastic uterus is observed, and her karyotyping was done in that 46 sexes. And final conclusion is MRHK syndrome is one of the most common causes of this primary amenorrhea, and ultrasound will be useful for diagnosing any associated renal anomalies, and the MRI will be more precise, and it is a less invasive and expensive than the laparoscopy. This condition has a psychologically devastating consequences, but now anatomical defects can be corrected surgically. So correct evaluation of the patient and proper management is a mandatory.
What are the other causes of primary amenorrhea?
Androgen insensitivity syndrome, man.
Yes. Other causes?
Constitutional.
How do you define primary amenorrhea?
Is there
Absence of
any role for
menstruation.
uterine transplant in your case, ma?
Madam?
Is there any role for uterine transplant in your case? Ovaries are normal.
Yes, madam, you can transplant.
Yes or no? I just want to know.
Yes, madam.
You said surrogacy, home donor, all that. Okay. What about the vagina?
Yes, ma'am. Vagina, she had a vaginal dimple,
Lower
ma'am,
third
of 1
development
centimeter.
is from where? Lower third of vagina development.
Sinovaginal bulb.
Sinovaginal bulb. Upper
Urogenetic
one
science.
with the Mullerian. So that is also absent.
Mullerian ducts.
So that is also absent here, right?
Yes,
So
madam.
will it help the uterine transplant? Will it help in this case?
No, madam.
You said
Uterine
yes,
transplant
and
can
no
help.
now. Give me one answer. You said yes in first and no second.
Madam, along with the vaginoplasty, you can have a uterine transplant, madam.
Have you heard anything such that? Okay, ma. Thank you.
Thank you, ma'am.
Next candidate, Dr. Vaishnavi. Dr. Vaishnavi. Dr. Varsha KR. Dr. Varsha KR.
Yes, ma'am.
Start sharing your. Dr. Varsha KR. Please share your PPT. Dr. Varsha.
Yes, ma'am. One second, ma'am.
Suramya?
Good morning, ma'am.
Good morning.
Dr. Varsha, we couldn't see your PPT.
Good morning, ma'am. Hello. Good morning, ma'am.
Yes.
Presenting a case of pregnancy complicated with hereditary spherocytosis. It is an introduction. It is a rare autosomal dominant disorder characterized by mild to moderate hemolysis. The membrane defect in this disorder is characterized by deficiency of spectrin or ankyrin, protein 4.2 or band 3 protein. These defects results in weakening of connections between skeletal proteins and lipid bilayer, changing the morphology of the cell from discocyte to spherocyte. The patient presents with no symptoms or symptoms like anemia, jaundice, and splenomegaly. Case report. We are presenting a case of 30-year-old primary gravida who was referred in view of fever, raised total count, unilateral lower limb swelling. She had family history of anemia with jaundice. She had no significant past or medical history. On examination, she had pallor and mild jaundice. All relevant blood investigations was done and she was found to have severe anemia, HB of 6.8 gram% with indirect hyperbilirubinemia. Peripheral smear showed spherocytosis with leukocytosis with chronic hemolysis. USG abdomen and pelvis was done and found to have splenomegaly. 2-pin PRBC was transfused. Genetic testing was done and confirmed that the patient has spherocytosis type 2 and the affected gene is SPTB gene. Management. At 38 weeks of gestation, she came with complaints of leaking PV. Labor was augmented by oxytocin infusion. She underwent full-term vaginal delivery with right medullateral episiotomy and delivered a single live, healthy female baby. Discussion. Hereditary spherocytosis presents with partially decompensated hemolytic anemia in childhood, who then become asymptomatic. Jaundice is apparent during viral infections. The clinical severity varies among families and even among patients with the same family. Diagnosis is made by anemia, decreased MCV, increased MCHC, increased reticulocyte count, elevated bilirubin, LDH, and presence of spherocytes in peripheral smear. Ultrasound can reveal splenomegaly and cholelithiasis in few patients. Although rare, the disease is characterized by spectrum of clinical presentation ranging from mild to severe anemia with jaundice and splenomegaly. Splenectomy is done in cases who are expecting severe hemolysis, preferably in second trimester. Obstetrician should exercise high index of suspicion to diagnose this entity as early as possible. Obstetrician should exercise high index of suspicion to diagnose this entity as early as pregnancy is diagnosed to yield better outcomes. Thank you.
Here was a baby screened. When was the diagnosis made?
The diagnosis was made at 32 weeks of gestation, ma'am.
So the next pregnancy, will you do anything different? Any genetic counseling?
Genetic counseling was done. Genetical testing was done, ma'am. It was found that she was having SPTB gene autosomal dominant disorder. So she was counseled. Genetical counseling was done for her.
What type of counseling? What was discussed in that counseling?
The inheritance of the baby having the autosomal dominant inheritance and the
so what is percentage of inheritance?
Huh?
What is the percentage of inheritance? Autosomal
50%,
dominant. 50%. Okay.
50.
So the next time it comes,
You are supposed to screen the previous child also?
No, ma'am. This was the first pregnancy.
Oh, this is the first pregnancy. I'm sorry.
Yes, ma'am.
So when she comes for the next pregnancy, will you do anything different, knowing that she already has hereditary spherocytosis?
We can correct the anemia. We can correct the anemia as soon as possible. And in this case, she had iron overload was there, ma'am. So we could not give iron supplements.
Okay. How was the iron overload diagnosed,
her serum ferritin levels were high, ma'am.
What was the serum ferritin level?
Around 328.
You're given in your presentation?
No, ma'am. Here it is not mentioned.
Okay, okay. Thank you.
Okay, thank you.
Thank you.
Next candidate, Dr. Yuvarani.
Yes, ma'am.
Kindly share your PPT and start presenting.
Lavanya, two more candidates.
Yes, ma'am. This is the final, ma'am. Dr. Vaishnavi and Dr. Shubhashri are absent today, ma'am.
Oh, they are not. Vaishnavi has not come. Okay.
Yes, ma'am.
So Yorani. Okay.
Last candidate, ma'am. Yes, ma'am.
Ma'am, good morning, ma'am. Is my PPT visible, ma'am?
No.
Ma'am, now, ma'am.
Yes, ma. You can start.
Good morning, ma'am. Myself, Dr. Yuvarani from GDMCH, postgraduate. My topic is obstetric cerebral venous thrombosis. CVT is an uncommon neurological condition which occurs during pregnancy and puerperium. In India, incidence is 4.5 per 1,000 deliveries. It is a challenging condition because of its clinical presentation, usually beginning with severe headache, which may lead to seizure, neurological deficit, and death. It occurs more commonly in cases of preeclampsia, sepsis, anemia, or when prothrombotic conditions are present. There is greater risk of CVT during third trimester of pregnancy and puerperium. Studies showed superior sagittal sinus to be the most common site of involvement, which leads to headache, increased intracranial pressure, and papilledema. The headache, which is the most common symptom, is usually progressive, atypical, does not respond to analgesics, and may develop over several days, leading to an average time between onset of symptoms and diagnosis of 7 or more days. Most of the patients referred to our hospital were within 48 hours of onset of symptoms. In patients with suspected CVT, investigations such as CBC, PT, INR, AP, TT, D-dimer should be done to rule out the cause. Eclampsia and CVT is more often confused with each other, and hence even after initiation of anti-epileptic treatment, one must rule out CVT with radiological findings. There is higher incidence of CVT in puerperium when compared to antepartum. Hypercoagulability plays an important role, and moreover, hypovolemia, which is secondary to postpartum hemorrhage, trauma during delivery, and venous stasis due to prolonged bed rest should be corrected. In cases of clinical suspicion of CVT, CECT is the first investigation to be done. The cord sign in NCCT is visualization of hyperdense thrombosed cortical vein, and dense triangle sign or empty delta sign, which is seen in CECT, is visualization of thrombosis. Gold standard investigation in the diagnosis of CVT is MRA with MRB because of increased sensitivity. Treatment, which is low molecular weight heparin according to the body weight, is overlapped with warfarin. Aim of INR is 2 to 3. In subsequent pregnancies, there should be prophylactic use of heparin from 28 weeks till 6 weeks postpartum. Early diagnosis and treatment will reduce the complications and improve the prognosis. This study was conducted in our hospital, in our department. It was a retrospective observational study from May to December. All cases diagnosed as CVT based on radiological findings were included. A detailed history, clinical examination, necessary blood investigation, and radiological investigations were done after getting informed consent. Total number of cases in my study was 20. The period of presentation was puerperium. Mean age was 26. Parity was second gravida. Mode of delivery was by C-section. Risk factors include obesity, most common, followed by dehydration. Associated high risks include anemia. 40% of the patients required blood transfusion. PAH 20% were on antihypertensives, and chronic hypertension superimposed severe preeclampsia seen in 5% of the cases. Duration of onset of symptoms is from 7 to 10 days. The most common presenting symptom was headache, which is seen in 60% of the patients, followed by seizures. Other symptoms include blindness, hemiparesis, and loss of consciousness. The most common site of infarct is superior sagittal sinus, which is followed by lateral sinus and transverse sinus. The first investigation we did in our study was CECT. Characteristic empty delta sign was seen in 10% of the cases. Investigation of choice was, however, MRA brain with MRA. Treatment we gave was anticoagulation with heparin, followed by maintenance on warfarin for 6 to 12 months to prevent recurrence, extension, and reocclusion for recanalization of the vessel till the target INR of 2 to 3 is achieved. Anti-edema measures were given, anti-epileptics, antibiotics, and supportive therapy was given. All patients in our study were recovered completely. Conclusion: CVT should be suspected in any women who develops neurological symptoms in pregnancy and puerperium. Evaluation to the obstetricians becomes easier if one has the knowledge of venous system and associated symptoms. Headache being an important symptom should not be ignored in patients with anemia and PH, especially in antenatal period. Early diagnosis and treatment will reduce the morbidity and improve the prognosis. Thank you, ma'am.
What is PRESS syndrome?
Progressive reversible encephalopathy syndrome, ma'am. It's
so. Could there be a permanent vision loss in CVT?
No, ma'am. It will be reversible, ma'am.
No.
Okay.
Which vessel occlusion can cause? Very rare.
Cavernous sinus thrombosis.
No. Retinal artery thrombosis. Venous thrombosis is common. Rare arterial thrombosis can cause permanent vision loss. Okay, when will you start warfarin? When will you start warfarin? Am I audible?
Yes, ma'am. Warfarin will be started on day 3 of starting of heparin, ma'am.
What is the role of CT versus MRI venogram? Which one is preferable investigation?
Ma'am, CT venography is done nowadays, ma'am. But we are preferring MRI with MRV.
That was which. Why you prefer MRI venogram? CT is comparatively cheaper.
Okay, ma'am. They have increased sensitivity and specificity, ma'am. Compared to CT venography, ma'am.
Any antenatal screening you prefer?
Ma'am, yes, ma'am. Like Apla syndrome, you have to screen, ma'am, and we have to check for any antithrombin C deficiency, factor 5, factor 2 mutation, like that we have to check, ma'am.
Protein C is
protein C, protein S also.
should also be included, right?
Yes,
Madam, to conclude. Madam, you would like to.
All your patients were in the puparium?
Yes, ma'am. All my 20 cases were in the purparium, ma'am.
You have seen any patient in the antenatal period?
No, ma'am. I haven't seen any patient.
Is first trimester also a patient might be predisposed due to any risk factor?
In first trimester,
the same risk factor you said, dehydration. So what condition?
Anemia, dehydration. Next.
First trimester. Hyperemesis patients.
Yes,
they are also prone for PVTs.
Okay.
So even in that trimester, we should have a high suspicion.
Okay.
Okay, pa, thank you.
Thank you.
Madam, shall we discuss the marks now, madam? After this, yeah.
Yes, ma'am.
Yeah. Shall we
Thank you
discuss
all
and
the
send it?
participants. Thank you, judges. Thank you, ma'am, for your patient cooperation. Thank you, ma'am. We'll proceed to the next session, ma'am.
Yeah,
Okay,
Lavanya.
Thank you so much.
Lavanya, I would like to have ma'am's number.
Yeah, ma'am. I'll share with you, ma'am.
Yeah,
Personally,
please.
I'll share you, ma'am. Yes,
Yeah.
ma'am.
Now itself.
Congratulations to all participants and
all
thank
the
you, madam.
candidates-
Thank you for the
Yeah.
judging.
All the candidates presented well. Selection of the cases were very good. And, the organizers, I congratulate for all the efforts. And I congratulate the candidates who have taken interest in presenting. Okay.
Thank you, ma'am. Thank you, ma'am.
Lavanya, please send ma'am's number. I would like to have a discussion.
Yes,
before
ma'am. Yes, ma'am. I'll send you now only, ma'am.
Yeah, now.
Yes, ma'am. Thank you, ma'am. For the next session, I warmly welcome our honorable judges, Dr. Rajeshwari and Dr. Usha Rani. Welcome you, ma'am.
Good morning.
Good morning, ma'am. Welcome, ma'am.
Good morning.
Welcome, ma'am. Shall we start the session, ma'am?
Yeah, you can start this.
Dr. Nandini B.
Yes, ma'am.
Dr. Yuvarani, kindly stop sharing your PPT. Dr. Yuvarani. Dr. Yuvarani, kindly stop sharing.
Okay, ma'am.
Do we have all the presenters for today?
Ma'am, totally there are 20, ma'am. But a few people are absent today, ma'am. We'll let you know. Yes, ma'am.
So
Is
first,
my screen visible, ma'am? Am I audible?
Ma'am?
Is my screen visible, ma'am?
No, it's not visible. Please share it.
first candidate is Miss Dr. Nandini.
Yes, ma'am. Dr. Nandini B.
Yeah.
Is my screen visible now, ma'am?
Yeah, your screen is visible.
Good morning, everyone. I'm Dr. Nandini, second year PG from Oxford Medical College. My case is a massive cystic degenerative leiomyoma mimicking an ovarian tumor. Leiomyoma is the commonest benign tumor of the uterus. When they enlarge and outgrow the vasculature, they result in various types of degeneration, such as hyaline, myxoid, red degeneration, and calcification. Hyalinization is the commonest type of degeneration. Cystic degeneration is a rare type. My patient is a 50-year-old postmenopausal woman who presented with abdominal distension, which was slowly progressive over 3 years with reduced appetite. She didn't have any significant pain, abdomen, vaginal discharge, or bleeding per vagina. On examination, general physical examination was nil contributory. Per abdominal examination, abdomen was uniformly distended. There were 2 distant masses felt. Mass number 1 was a cystic mass corresponding to 28-week gravid uterus lying over the umbilical, right lumbar, right iliac fossa, which was smooth in surface, mobile in both horizontal and vertical dimension, non-tender. Mass number 2 was a firm mass 10 into 6 centimeter over the left lumbar region with restricted mobility. It was non-tender and lower margin corridor. First examination, cervix and vagina was healthy. Cervix appeared to be pulled up. On bimanual examination, uterus was bulky and displaced towards the left. And there was a cystic mass which is appreciated corresponding to 28 weeks gravid uterus, which was mobile, felt separately from the uterus, occupying the posterior and the right fornix. On further investigation, TBC and other basic blood investigations were within normal limits. TECT, abdominal pelvis, uterus was bulky. Ma'am?
I can ask you some questions. It's a poster, right? So we've gone through it. So clinically, what did you think it was?
Ma'am, I thought mostly it was an fibroid uterus along with the
Hello?
Hello, ma'am. I thought uterus along with the
You're not audible, Nandini.
Am I audible now, ma'am?
Yeah, you are audible now.
Yes. I thought it is an ovarian cyst along with the fibroid, ma'am. Uterine fibroid.
Clinically?
Ma'am, can you hear me, ma'am?
Yeah, now I can.
Yes, ma'am. Clinically, I thought it is an ovarian cyst along with uterine fibroid, ma'am.
So what kind of preoperative preparations did you do? You thought it was benign or malignant?
We had done our ovarian tumor markers, ma'am. All the markers were within the normal limits. So with imaging diagnosis and with the tumerian markers, we thought it was a benign ovarian cyst, ma'am.
You think it could have been managed laparoscopically since you thought it was benign?
Yes, ma'am. We could have managed laparoscopically.
Yes?
Yes, ma'am. Yes, ma'am.
Yes or no?
Yes, ma'am. Yes, ma'am. It can be managed laparoscopically.
You would do it?
No, ma'am. It wasn't expletive. We wanted to see intra. We wanted to assess the mass. So we wanted, and it was a very big mass, and there were 2 masses palpable. So we wanted to do open for further management.
You should have said an affirmatory no to laparoscopy, right? For a 50-year-old postmenopausal lady, you didn't want to spill it.
Okay,
am I right?
Yes, ma'am.
Not put in a scope for such a large one, even though you think it is a benign. You never know. You would only upgrade the whole tumor. Dr. Rajeshwari would like to ask some questions, please.
So, what will the preoperative evaluation will do to confirm whether it's a benign or malignant? It's a preoperative evaluation you would like to do for such a huge pelvic mass.
Yes, ma'am. We'll go with imaging modalities. Basically, we could do soft tissue imaging. We can do MRI, ma'am, with contrast, abdominal pelvis. And since clinically we were suspecting it as such a huge mass of ovarian origin, we wanted to do tumor markers, ma'am.
Yes. Yes, ma'am.
So shall we go ahead with the next poster?
Yes.
Yes, ma'am. Dr. Ritika Periasamy.
Yes, ma'am. Yes, ma'am.
Start sharing.
Ma'am, is my presentation visible, ma'am?
Yeah.
Okay. Can I start, ma'am?
Yes, ma'am.
Yes, please.
Yeah. Good morning, ma'am. My presentation is today about acardiac
Can you put
AKFLS.
it on the slideshow?
Okay, ma'am. Yeah. Okay, ma'am. Is it fine, ma'am?
No. Yeah, proceed with the presentation.
Just
Proceed.
slideshow.
Good. Ma'am, if I put in slideshow, it's not visible, I guess.
Not visible, is it? Okay, fine. Go ahead, press.
Okay, ma'am. Okay. Good morning, ma'am. Today my presentation is about acardiac AKFLS, a twin reversed arterial perfusion sequence in monochorionic pregnancy. Acardiac AKFLS or twin reversed arterial perfusion is a complication of monochorionic multifetal gestation, which has an incidence of 1 in 35,000 births. The one of the twin will act as a pump twin, which will supplying the blood via abnormal vascular anastomosis, with the resultant high output congestive cardiac failure in the pump twin, so which occurs secondary to the strain of perfusing the acardiac twin, thus creating a reversed vascular anastomosis in which the blood, abnormal vascular connection. Arteries usually they will carry blood away from the fetus and towards the placenta to receive oxygen from the mother's circulation. Whereas in this acardiac twin, the unique vascular connections allow blood in the artery to flow in the reverse direction, that is towards the acardiac twin rather than away from it. The acardiac twin will undergo secondary atrophy and it is non-viable. The pumping twin is under a high stress, especially cardiac stress, and is prone to develop cardiac failure. The AR objectives of the study is to describe the pathology and the etiologic factors, and to emphasize the need for an early diagnosis and adapted therapeutic management to improve the prognosis of the pump twin. Case report: a 23 years old Mrs. XY, who is parity G3A2, was referred to our hospital Sri Siddhartha Medical College at 28 weeks of gestation, with chief complaints of sudden abdominal distension and breathlessness since 2 days, and with severe preeclampsia. The examination.
If PowerPoint get a like I have a PowerPoint. Like
examination revealed hugely distended uterus and well effaced cervix with patulous os. Ultrasound, which was done on the same day, it revealed monochorionic diamniotic twin with an amniotic fluid index of about 36 centimeter, and twin A with absent cardiac activity, and twin B with acardiac AKFLS. The patient was counseled for termination of pregnancy and was induced with misoprostol and delivered a first twin A, which was weighing 780 grams, followed by acardiac twin B, which was delivered weighing 400 grams. It had absent head and upper limbs, absence of thoracic region, but with preservation of the lower limbs, genitalia, and the abdominal viscera. The placenta weighed around 300 grams with the attachment of 2 umbilical cords. The patient was discharged on 8th postpartum day. Discussion: the complications are more with monochorionic twin gestation because of the placental sharing. The acardiac twins are classified into 4 categories based on the morphological malformations.
Sorry to interrupt, ma'am. It's time for discussion.
Okay, ma'am. Yeah, ma'am.
3 minutes for presentation and 2 minutes for discussion, ma'am.
Sure.
So you complete your presentation here. Different
types of acardiac twins.
Yeah, ma'am. Acardiac AKFLS, acardiac anceps, acardiac acormus, and acardiac amorphous. So the incidence of multifetal pregnancies has increased due to assisted reproductive technologies. Although
Now, 1 second, Ritika. You think you could have saved this baby if you had done an early ultrasound and picked it up earlier?
Yes, ma'am. Serial ultrasound assessment is mandatory, ma'am. At least starting from 16 weeks, every 2 weeks is essential. Until 24 weeks, every 2 weeks. Ma'am, we have to intervention could be depending upon the pump twin, ma'am, status of the pump twin. If the pump twin, we can if it is has chances of survival and there is no chances and there are no any features of cardiac failure, we can intervene. It could be our main aim should be to interruption of the vascular anastomosis, ma'am, which could be done by any laser photocoagulation or ablation or ligation via fetoscopic procedures. Depending upon the gestational age.
How early could diagnose this? So that you can save the normal. How early gestation?
How early? Ma'am, chorionicity is usually determined at around 11 to 14 weeks, and early, depending upon the gestation age and availability of in procedures and skills, ma'am, like around 16 to 27 weeks, we can intervene depending upon the status of.
What intervention you like to do?
Ma'am, like endoscopic ablation, radio frequency, laser ablation, ma'am, high frequency.
What?
Ablation of the vascular anastomosis, ma'am, vascular umbilical artery anastomosis, ma'am.
Umbilical artery anastomosis, which is the most dangerous anastomosis in MCA maintenance, which is causing all the pathology. Which is the anastomosis which is causing all the pathologies?
Arterial anastomosis and veno.
Which is more dangerous, arterial or
arterial? Arterial and venous anastoma.
Okay. Any questions, Madam Usharani, madam? Usharani, madam, any questions?
Yes. I think we're also running short of time.
Oh, sorry, ma'am. Time is up, ma'am.
Yeah. That's enough. Thank you.
Thank you.
Candidate Dr. P. Sushma Shri. Dr. P. Sushma Shri. Dr. Rupita.
Ma'am.
Dr. Ritika, kindly stop sharing.
Yeah, yes, ma'am. Yes, ma'am.
Dr. Rupita, share your PPT.
Is it visible, ma'am?
No.
No, it's not visible.
1 second, ma'am. Ma'am, is it visible now?
Yes.
Yeah, now it's visible.
Good morning. I'm Dr. Rupita from Mahatma Gandhi Medical College. I'm going to present a rare case of giant uterine lipoleiomyoma masquerading malignancy in reproductive age. Leiomyoma is the most common benign uterine tumor in women of reproductive age group. Lipoleiomyoma is a rare benign variant of leiomyoma most commonly occurring in postmenopausal age. Hereby, we report a rare case of giant lipoleiomyoma mimicking leiomyosarcoma. A 13-case report. A 39-year-old multiparous woman came with complaints of progressive abdominal distension for 2 years with rapid increase over the last 6 months without menstrual irregularity. Clinical examination revealed uniformly enlarged mass occupying the whole abdomen from pubic symphysis to 4 centimeters below the xiphisternum with variable consistency. MRI showed enlarged uterus with a large mass of size 23 into 24 cross 15 centimeters with heterogeneous echogenicity causing compression over both ureters. Provisional diagnosis of uterine myoma or uterine sarcoma was made and patient underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy. Intraoperatively, a single fundal intramural fibroid of 28 cross 22 centimeter with variable consistency weighing 5.3 kg was removed. The histopathology revealed lipoleiomyoma with a hyaline degeneration with no features of malignancy. Uterine lipoleiomyoma is a subset of leiomyoma with incidence of 0.03 to 0.02%, commonly occurring in postmenopausal age group. It is composed of an admixture of mature smooth muscle cells and adipocytes. Immunohistochemical studies reveal a complex histogenesis of lipoleiomyoma, which might arise from metaplasia of uterine smooth muscle cells or from immature mesenchymal or ectopic embryonic fat cells. However, fatty metaplasia is the most acceptable theory because there is no evidence of lipoblast, atypia, and adipocytes or necrosis. They are often seen in obese postmenopausal women who who remain either asymptomatic or present with similar.
Can I stop you here, Rupita?
Yes, ma'am.
Suppose this has happened in an nulliparous lady, what would you have done?
Ma'am?
If it happened in a nulliparous lady.
Ma'am, in an nulliparous, we could have investigated, ma'am, and if she has completed her family, sorry, ma'am. If it is 40-year-old or according to the age.
What I'm trying to say is, if she wants to have children, what would you have done?
Ma'am, we would have proceeded with the surgery, and we would have explained her for other options to adopt or.
Was this a benign mass or a malignant mass?
Ma'am, this was a benign mass, ma'am. We were suspecting it to be a leiomyosarcoma owing to the progression.
When you did the hysterectomy, were you able to do the myomectomy easily on the specimen? Were you able to enucleate the myoma from the specimen?
Yes, ma'am. Yes, ma'am. We were able to enucleate the myoma from the specimen, ma'am.
So you could have done a myomectomy if she had wanted a baby.
Yes, ma'am.
What kind of precaution would you have done before proceeding? Suppose it was a malignancy.
Sorry, ma'am?
You were suspecting a sarcoma, right?
Yes, ma'am.
The lady doesn't have a child. Doesn't consent for a hysterectomy.
Yes, ma'am. We would have taken a consent for hysterectomy, ma'am.
She does not consent for the hysterectomy. She wants a myomectomy.
Yes, ma'am.
How would you have tailored your decision? Any other questions, Rajesh?
Yeah, what is the preoperative prediction? How could I mean? Why? What are the things in favor of malignancy in your case? Why did you suspect malignancy in this case?
Ma'am, because of the she didn't. Ma'am, because of the fast growth, ma'am, rapid growth over she complained of abdominal distension, which was which was there for 2 years, increased suddenly from the past 6 months, and the size and the consistency of the mass, ma'am, it was firm, and there was variable consistency on examination, and in MRI it was a hyperechogenic mass, ma'am. So we suspected it to be malignancy, ma'am.
Any tumor markers? Any tumor markers?
Yes, ma'am. We did tumor markers, ma'am. We have sent ovarian tumor markers for her, and
to have a suspicion of leiomyosarcoma, any tumor markers you are aware? Yes. Thanks. Thanks, Rupita.
Thank you, ma'am.
Thank you, ma'am. Next candidate, Dr. Madhavi L. Dr. Madhavi L.
Yes, ma'am.
Start sharing.
Is it visible, ma'am?
Not yet. No.
Dr. Madhavi, your slide is not visible.
Just a minute, ma'am. Is it visible, ma'am?
Not yet. Yes, ma'am.
Is it visible, ma'am?
No.
It's not visible. One more minute, ma'am. Just a minute. Is it visible, ma'am?
No. The slide is not visible.
Just a minute, I'm sorry.
Yes, now it's visible.
Yes, ma'am. Shall I start, ma'am?
Yes, proceed.
Yes, ma'am. Good morning. I'm presenting a rare case of uterine angioma in a middle-aged woman. So it is a very rare benign tumor. It forms in the process of angiogenesis when the vascular walls thicken due to the proliferation of smooth muscle cells. On imaging, the diagnosis is very difficult, and the final diagnosis is usually obtained with the post-operative histopathological examination. These cells are immunoreactive for smooth muscle actin, desmin, H1 with a low proliferative index labeling index. Because these lesions are vascular, they may undergo spontaneous rupture and pose a life-threatening emergency, especially in pregnancy. So my case is a 40 years old multipara with a previous history of myomectomy 14 years back. She now presented with a complaints of heavy menstrual bleeding with dysmenorrhea for the past 1 year. So detailed history was obtained, and periabdominal examination showed a vague mass corresponding to 16 weeks, and it was more towards the left lumbar and left iliac region. A bimanual examination was done, which revealed uterus. Uterus size was only like around 10 weeks with a huge like exophytic mass, which was mobile side to side up to 20 weeks in size. A transabdominal sonography was done, which revealed a 12 into 11 centimeter uterine subserous fibroid in the midline and more towards the left side. So, and then we proceed, we plan for total laparoscopic hysterectomy and bilateral salpingectomy. So, diagnostic lab was done when I started with the procedure. A huge mass was seen. The uterus was like 10 weeks size with a biloculated, regenerated, suspecting subserous fundal myoma with areas of hemorrhage and necrosis. And there were also multiple exophytic grape-like cystic growths over the anterior and posterior surface of the uterus, over the UV fold of peritoneum, over the anterior wall of the rectum, and also the lateral pelvic side walls, and also in the small intestine, some grape-like cystic growth was visualized. So suspecting it to be some malignancy, sarcomatous change, we got the assistance from gynae onco, and they suggested to convert it to an open hysterectomy. And then the patient was not willing for oophorectomy. So after consulting them, they said that even if it is a sarcoma, ovaries can be preserved. And then we proceeded with the midline vertical incision, and so that the specimen can be retrieved as a whole. And total abdominal hysterectomy was done with bilateral salpingectomy. And peritoneal fluid, bloodstained peritoneal fluid was present. It was sent for cytology, which was negative. And post-operatively, histopathological examination revealed neoplasm composed of spindle cells arranged in sheets and vesicles in a myxoid matrix with extensive areas of hemorrhage. And no necrosis was or brisk mitosis was seen. Immunohistochemistry was positive for Caldesman, smooth muscle actin, and KI 67 or 4 to 5%. And so yes, ma'am. And conclusion, it was an angioma. It is a benign tumor, so complete excision of the lesion remains the mainstay treatment. And as of now, no recurrence has been reported, and have a good prognosis if the tumor is completely excised.
What about the grape-like lesions in the peritoneal cavity, widespread septal? What was the histopathology of that?
Ma'am, that was also cystic lesions, ma'am. Cystic necrotic lesions with areas of hemorrhage, ma'am.
That has been biopsied or?
Yes, ma'am. That was sent for biopsy. That mentioned it as a cystic hemorrhagic lesion, ma'am. The size was around 1 into 0.5 centimeter only.
You had not picked up any of this thing in your imaging?
No, ma'am. No, ma'am. Actually, no. We didn't pick anything, and
What
we didn't go
imaging
for
was
it.
done?
Ma'am.
What imaging was done?
Just that trans-abdominal sonography and trans-vaginal sonography, ma'am.
It's a 20-week size mass.
Yes, ma'am. We didn't go for any further
What is
imaging.
the role of higher imaging? What is the role of higher imaging in preoperative workup in such a huge fibroid? Such a huge abdominal pelvic mass.
Yes, ma'am. It was missed actually.
She had any previous history of myomectomy or something?
Yes, ma'am. Previous history of myomectomy. She didn't have the reports with her, ma'am. Verbally, she said it was an 8 centimeter myoma, ma'am. So
she had a laparoscopic myomectomy?
No, ma'am. Open myomectomy only.
How many years ago?
14 years back.
You told that in your history now? Yeah.
Yes, ma'am.
14 years back. Okay. Because lap myomectomy, sometimes you can have spillage of all the material and peritoneal.
Okay, ma'am.
So what follow-up should this lady be on?
Yearly follow-up scan for ovaries, ma'am.
Thank you. It was interesting.
Thank you, ma'am.
Next candidate, Dr. Usha Nandini Senayan. Dr. Usha Nandini Senayan. Dr. Usha. Moving on to next candidate, Dr. Divya Ravi Kumar.
Yes, madam. I'll share my screen.
Dr. Madhavi, kindly stop sharing the screen.
Madam, am I audible and is my screen visible, madam?
Yeah. Proceed.
I'm here to present my poster on Look Into My Eyes and What Do You See? A case series on microphthalmia. Microphthalmia is a condition wherein the intraocular distance is less than 5th centile for the period of gestation, which can be diagnosed by our standard ultrasound. And anophthalmia is a condition which can be confirmed only postnatally. Both these conditions are rare congenital fetal anomalies, which can be present as isolation or as a part of a genetic syndrome. And why we give so much importance is that it is one of the common causes of congenital blindness, and the baby once delivered needs cosmetic support and counseling regarding what to expect from in terms of visual acuity is also very important. So I have 4 cases. The first case was a 28-year-old multiparous woman with a previous child with unilateral anophthalmia. She came to us at 12 weeks of gestation, and we were able to image the fetal orbits along with the lens. But because of her previous history, we had called her back on at 16, 17 weeks for an ultrasound. And we found that both the orbits were less than 5th centile for the period of gestation. And this was counseled, and the patient opted for invasive testing, karyotyping, and DNA storage was done. And the patient terminated the pregnancy, and autopsy was not done. In the second case, she was a second gravida with previous abortion. First trimester screening not done. She had come to us at 19 weeks and we had diagnosed microphthalmia. Patient terminated her pregnancy. No prenatal testing was done. But on autopsy, we found that there was synostresis, which is fusion of the eyebrows in the midline, low hairline, and low set ears. DNA storage for this patient has been done. The third case is a 36-year-old multigravida with gestational diabetes mellitus who had done her targeted scan elsewhere, which was given to be a normal study. And she came to us at first visit at 29 weeks. The biometry was found to be corresponding to the period of gestation, but while doing the anatomical survey, we noticed that the fetal orbits were less than 5th centile for the period of gestation, and microphthalmia was diagnosed. Moving on to the examination of the heart, we also diagnosed unbalanced ABSD. The baby did not make it, and the post natal images of the baby showed dysmorphic faces with microphthalmia, post-axial polydactyly, and pinna abnormalities, as well as an abnormal hairline.
Divya,
Yes, madam.
what message would you like to give to us with all this?
Imaging of the fetal orbits is now included in the first trimester screening as well as in the second trimester targeted screening by all the standard bodies. And why we have to, we should always have an index of suspicion when imaging the size of the orbits or the distance between the orbits is found to be abnormal. We have to measure them and plot them in nomograms so that we can diagnose these conditions even prenatally and counsel the prospective parents, because these conditions are an important cause of congenital blindness.
What counseling you will offer the patient when you're diagnosed with microphthalmia? What counseling you will give to parents?
Microphthalmia is associated at least with 50 of monogenic disorders, infections, as well as teratogens. Hence, we would strongly recommend them to undergo a prenatal testing, basic karyotyping, or a microarray, along with DNA storage if the patient opts for termination of pregnancy. And post, if the patient opts for termination, postnatally also, we would like to do an perinatal examination, because phenotyping these fetuses will help us in counseling for the future pregnancies.
Do you find cases with recurrent microphthalmias?
Yes, madam. Conditions like Walker-Warburg, Golden Heart, they have an autosomal pattern of inheritance, and hence microanophthalmia can be a recurrent condition as well. And we have even one case who had a previous child with unilateral anophthalmia.
Dr. Raji, any other questions?
Yes, ma'am. Yes, finished. We can go for the next two.
Thank you, Devi.
Thank you.
Thank you, ma'am. Next candidate, Dr. Balaniveda M.
Yes, ma'am.
Kindly share your PPT and start presenting.
Yes, ma'am. Is my screen visible, ma'am?
Yes.
Okay.
Yes.
Yes, ma'am. Good morning, ma'am. I am Balaniveda from IGMC RI Puducherry. I am here to present a poster on abdominal wall endometriosis. It is indeed a very rare form that succeeds any abdominopelvic surgeries with an incidence of 0.03 to 0.45%. And in general, the risk of malignancy for any endometriotic spots is 1%. So though this is such rare, women with chronic cyclical pain at the scar site and women with complaints of mass palpable per abdomen should be suspected with scar endometriosis amongst other differential diagnoses. Moving on to the cases. Case 1 is a 31-year-old para-2 live 2 with previous 2 LSCS. She came with the complaints of chronic cyclical menstrual pain for the past 2 years. On examination, there was a tender mass of size 2 × 3 cm over the LSCS scar site as shown in the image 1. On ultrasound, we found an ill-defined hypoechoic lesion in the subcutaneous plate with the extension up to the rectus sheath. Intraoperative findings were suggestive of endometriotic fibrous tissue of size 7 × 6 × 5 cm, more on the right side of the scar extending up to the rectus sheath, and the tissue was sent for HPE, suggestive of anterior abdominal wall endometriosis. And moving on to the second case, it is a 35-year-old para-2 live 2 abortion 1. She has a history of previous 1 laparotomy for ectopic pregnancy. She had come with the similar complaints, and MRI was done. As in USG, we cannot find any findings. On MRI, 2.3 × 1.3 cm T2 hyperintense and T1 hypointense lesion was found. The extension was up to the rectus muscle. Intraoperative findings were suggestive of anterior wall endometriosis of size 5 × 4 cm below the umbilicus and infiltrating up to the rectus muscle and rectus sheath. HPA report was suggestive of endometrioma. The third case was 35-year-old para-1 live 1 with previous 1 LSCS, and she has a history of removal of suture site granuloma with similar complaints. And
yes, Dr. Niveda.
Yes, ma'am.
So, what do you think is common among all these cases? What do you think would be the risk factors for development of such scar?
Ma'am, history of previous abdominal pelvic surgeries anytime in her life, ma'am. And they all present with the common complaints such as cyclical menstrual pain and mass palpable per abdomen, ma'am.
I think any kind of a surgical technique or anything that you should do during these C-sections predisposes them to have scar endometriosis.
Yes, ma'am. Saline wash usually tends to dispose the tissue, and the tissue tends to get deposited on the skin or subcutaneous plane, leading to development of scar endometriosis, ma'am.
This is your proposition, or has it been proved?
It has not been proved, ma'am. There are studies reporting saline wash, ma'am.
Saline wash should be done or should not be done according to them?
According to the studies, saline wash should be done, ma'am.
Okay. So when you had removed these endometriomas, did you have to do any mesh repair of the rectus sheath in any of your cases?
Yes, ma'am. In one case, it was 7 cross 6 cross 5 centimeter tissue we have excised, ma'am. So to close the repair, we had done mesh repair, ma'am.
Suppose you have to do a repeat section through that. Do you anticipate any trouble?
Yes, madam. It usually heals with the process of fibrosis. So in a repeat section, we will encounter difficulty in entering the anterior abdominal wall, ma'am.
Can this respond to medical therapy?
Many medical therapy has been tried before going for surgical treatment like NSAIDs and GnRH analogs, ma'am. But the symptoms were not relieved, ma'am.
What do you think? If you have a case, will you give her medical therapy?
No, ma'am. Better would be wide surgical excision, ma'am.
Stop it, Anjali.
Yeah, when will you decide for mesh repair in these patients? Is the size of the mass or anything else?
The depth and extent of the mass, ma'am.
What do you mean by the depth?
The layers of the anterior abdominal wall, which is being infiltrated by the endometriotic spots, ma'am.
Okay. Yes. Yes, ma'am. Any other questions, Ujjarani, madam?
No, nothing. Thank you, Dr. Girish.
Thank you, madam. Thank you, ma'am.
Thank you, ma'am. Next candidate, Dr. Neha Karen Fernandez. Are you here? Dr. Neha Karen Fernandez. Moving on to next candidate, Dr. Reshma Meena. Dr. Reshma Meena. Dr. Satyasila. Dr. Satyasila. Dr. Usha Nandini. Dr. Usha Nandini. Can you hear me, ma'am? Yes, ma'am. Kindly share your PPT and present, ma'am.
Good morning, ma'am. This is Dr. Usha Nandini. So actually, I got an email confirmation for oral presentation, ma'am. Yesterday evening only, I got an email for it was converted to a poster, which I didn't realize. So if it's okay, I can just do this as a quick 5 minutes presentation, ma'am. Hello? Hello? Hello?
The organizers will have to tell us that.
The organizer has to decide, no?
Because the confirmation which I received was paper.
Go ahead and present them quickly.
Okay, thank you very much, ma'am. So I'm Dr. Usha Nandini from Tiny Hearts, Tanjavur. So my topic is prenatal genetic testing in families with suspected single gene monogenic disorders in a resource constrained setting. So we all know what is monogenic disorders, and there are various modes of inheritance. And we being in periphery, we have real challenges in identifying these families because we belong to a small delta district in central Tamil Nadu, where agriculture is the main way of economy for patients, and we do not have any private or public sector which is doing genetics workup per se. So they have to travel at least 500 miles from here to go and get a genetic consultation done. So the ideal genetic clinic, we all know that it has to be a proper history, and then there has to be a genetic counselor who looks after the patient or the child or the family, and then go for a pre-test genetic counseling, and then the actual genetic testing, and then the post-test genetic counseling, and the results should be explained to the patient and be decided from then on. So for us, our modified workflow is like this. We do data collection with trained staff nurse, and we doctors, we do the pre-test genetic counseling, and again the pre-test social aspects and all the other aspects are dealt by our trained staff nurse, and she does all the genetic counselor work in our small unit. And then genetic counseling and the treatment aspect and the prenatal interventions will be looked after by a fetal medicine specialist and a pediatric cardiologist. So these are the number of referrals we got in this past 2 years since we started our practice. So it's 56 number of cases have been referred, thinking that they could be suspected monogenic disorders. And after our history and detailed pedigree, like we found that 21 were eligible for further evaluation. And out of these, the 6 of them had previous genetic testing done, and 15 of them did not have genetic testing done. And we evaluated all those according to the whether the proband is alive or not. So preconceptional referral were 5, and early pregnancy referral numbers I have quoted here. And the referrals are usually late. In our setup, it's usually late because most of them do not know the concept of preconceptional genetic testing. So the awareness is less. So usually they present to us at 11 weeks, between 11 weeks or during the second trimester. So out of these patients, we identified pathogenic variants in 16 of them, and we concluded that it's more likely to be a non-pathogenic problem in 35 of them, and no pathogenic variants were identified. Mutation was identified in 5 of them. So these were our numbers, and we did prenatal testing. We do amniocentesis, villus sampling, and all those these families. And we identified positive variants in so many people, both in proband testing, as well as in the family member couple testing, as well as in the fetal prenatal testing. So this is our data in the past 2 years. So where we evaluated thoroughly 16 families, and we identified the mutations of various homozygous, compound heterozygous, and autosomal dominant, and so on. So the major challenges we faced was, like as I said, the late referrals, because the window period is much less when the woman is already fallen pregnant. We do not have enough time to evaluate, and it puts so much of pressure on our team as well as on the family to get the results quickly, so that we can help the family by having an unaffected child. So financial constraints, as we all know, but still the genetic testing is the cost is coming down, especially in the peripheral areas. The testers are very much possible with a proper evaluation, and we need to identify the proper test. That is the most important thing, because when we came from overseas and when we started our practice here, most of the people were usually referring for karyotyping, which is totally unrelated to suspected monogenic problems. So if we can narrow down our diagnosis and do a proper pedigree workup and clinical workup, we can just choose one test where we were almost 95% successful in helping the family throughout. And I have just put few cases where we worked out, and it was really challenging. And the first case, they were referred for preconceptional consumate, second degree consummate couple. The first child died at 10 months of age because of unknown reason. And what we did was, our cardiologist and we just looked at the old reports, and we saw the child's previous echo report where the child died and was evaluated in Madurai. And the pictures were typical of hypertrophic cardiomyopathy. So this was the ECG of that previous child, the deceased child. And we felt that it is strongly suggestive of Pompe's. The genetic diagnosis was not done, but the parents had preserved the umbilical cord remnants. And it was the first time we approached a lab. We approached several labs and finally found out a lab who was willing to attempt a sequencing of DNA from this umbilical cord remnant. And we were able to do a gene sequencing and identify that the child was affected child with Pompe's, which is a homozygous condition, autosomal recessive condition. So from this has been published in American Journal of Genetics last year. So and second case is a proband negative.
The child had retrospectively, when we saw the reports antenatally, the child was diagnosed as dilated ventricles, but no further evaluation was done. The child was 6 years old when they came to me, and with global developmental delay and with multiple seizure episodes throughout, and MRI was abnormal. The thing was, the child was not genetically evaluated in the past. Instead, the parents have been advised to go for genetic testing by somebody, and they had done the genetic testing without even evaluating the proband, and the results were stated to be normal for the parents. So they came to me asking that why is the reason that the first child was affected, and what is the chances that it's going to happen again. So I had to make them understand thoroughly what is genetics and what is genetic counseling. And what we did was the exome sequencing for the index affected child, and we found out that the child had pontocerebellar hypoplasia, which was an autosomal recessive condition. Then again, we looked at the raw data of the parents. We just went and approached the lab where they did the exome sequencing for the parents, and we pulled out the raw data and we interpreted, and we found that the parents were carriers for pontocerebellar hypoplasia, which was completely missed. So the point here is index child evaluation is the key for genetic evaluation of monogenic problems. In the last case, the fetus is a proband, a third-degree consanguineous couple. So the previous pregnancy was terminated at 20 weeks because of complex cardiac problem. Again, we looked at the old reports. Though it was not done by a pediatric cardiologist in the past, we just saw that the pictures were suggestive of single ventricle with single outflow.
Usha, Nandini.
Yes, ma'am.
Yeah, it's a wonderful study. But can you just tell us what exactly you want to convey to us at the end?
The point is, the accurate diagnosis and predictive testing of monogenic disorders can be performed in a resource-limited setting, like a small setup, and we need to accurately match the phenotype with the genotype of the proband, so that we can help these families even in smaller places. So appropriate history, proper pedigree analysis, and the correct testing will lead us to go in the right path to diagnose the monogenic problems in a family, so that they can undergo a prenatal testing and they can have an unaffected child.
Do you have your own lab to do all this, or do you send the samples elsewhere?
We send samples elsewhere, but the interpretation we do ourselves. So a lot of times we just don't go with the lab results. We look at the variant analysis and we do the variant interpretation in our own hospital.
Interesting things that you're doing there. How long will it take for you to get the report back?
Usually, if the mother is not pregnant, we take like 2 to 2.5 months for us to evaluate properly, ma'am. But in these, like I have at least done 5 amnios in the pregnant mother, where we had to, we should expedite the process, and we approach the labs to get the raw data as quick as possible, so that we can do the analysis quickly, and at least before 24 weeks, we do amniocentesis.
How does it differ from simple karyotyping?
Karyotyping is to look at the chromosomes.
Yes.
Genes is to look at the structures inside the chromosomes.
Yes.
So it's like 23 pairs of chromosome can be compared as a 23 chapters in a book.
Yes.
So if a chapter is lost, then that is a chromosomal problem. If a page
how many of these genomes are you able to actually look at?
Sorry, ma'am?
How many of the entire genome are you able to actually look at?
So 8,000 genes, ma'am. Generally 8,000 genes. Those are the most of the inherited problems and pathogenic variants are covered with that 8,000 genes. So we usually send for that kind of testing.
How much does it cost?
In our setting, it costs around 25 to 30,000 bucks, ma'am, which is much lesser than the tertiary places, because our patients may not be, like affordability is a big problem. So it's a big challenge. Initially 2 years ago, that was the biggest challenge for us. So
but your labs are supporting you with that kind of money?
Definitely, yeah, definitely. Because our positive cases are much higher because we are supposed to choose that kind of cases.
With an amniocentesis sample, how much are you able to evaluate?
For what, ma'am?
With an amniocentesis sample, are you able to look at all the 8,000 genomes?
Of course, yes, ma'am, of course.
And within how much span time?
The general TAT time, the turnaround time, which is stated by the lab, is 6 weeks. So we tell the patient it's 6 to 8 weeks.
So what gestation are you doing the amniocentesis?
Up to 23, 24 weeks, ma'am. I haven't done for 24 weeks, like the latest one which I did was at 20 weeks.
So we were able to get the report within 3 weeks for that patient. So by 23 weeks, the report was released, and fortunately, the baby was not affected. So the one
around 16 weeks or something, the amniocentesis, is it not feasible?
16 weeks is definitely feasible, ma'am, but we need to find out the exome report of the affected child first. So what will happen is, if a patient comes to me at 14 weeks, for example, then I will advise them to get the proband evaluation first, so which will take 6 weeks, so that I can do the amniocentesis at 20 weeks. If they come at 8 weeks, I ask them to do the proband testing immediately, so the reports will be with me at 12 weeks, and then I do a CVS in that case.
So how does proband differ from genome?
Proband is, the definition for proband is the affected child, ma'am, affected family member. So if there are multiple members in the family having hearing loss, then we need to evaluate at least one member of the family, preferably the parents or the siblings, like whomever is affected. That's the proband. So we need to identify the problem in the proband, and then we have to go and look for the same thing in the fetus.
If you have only previous fetal losses without any affliction, then how will you proceed?
Then we thoroughly counsel them, and then we do the gene testing for the couple.
For the couple?
Yes, for both of them.
I have only one question, Dr. Usha.
Yes, please go ahead.
Suppose if you don't have the genetic diagnosis of the proband or the index child, are you going to analyze all the F2 genes?
Yes, ma'am. That's the only choice we are left with. That's the only choice we are left with.
How long it will take for you to give the report?
Again, 4 to 6 weeks.
4 to 6 weeks. But 20 weeks, sure. Okay, 20 weeks, 28 weeks, we are getting the report. So almost a viable fetus.
Yes. In that case, I just explained them, and if it is beyond the index child, we need to have the actual diagnosis by 20 weeks. Beyond that, it's really very, very challenging, ma'am. It becomes very difficult. Then I tell them that they have to face it, and we'll see what happens to the next pregnancy.
How about chorion-Willis sampling or early amniocentesis, Dr. Usha?
Yeah, it's very useful, ma'am. Only thing is, say for example, if the couple have the diagnosis before they fall pregnant, then I do a CVS at 11 to 12 weeks. So by 15 weeks or 16 weeks, they will have the report. The child is affected, terminate. The child is a carrier or unaffected, they happily continue the pregnancy.
Lovely work that you're doing. Thank you so much.
Thank you very much, ma'am. Thank you very much for.
Thank you, ma'am.
Thank you.
Candidate, Dr. Purnaveni Mohan. Dr. Purnaveni Mohan. Moving on to next candidate, Dr. Kavya. Dr. Kavya. Dr. Ashwini. Dr. Ashwini.
Yes, ma'am. Shall I share my presentation?
Yeah. Dr. Ashwini.
One second, ma'am. Is my screen visible, ma'am?
Yes.
Shall I start my presentation, ma'am?
Yes.
Okay. I'm Dr. Ashwini, working in PSG Hospital, Coimbatore. We had an interesting case, which I'm going to present. This is a lady whose pregnancy was complicated by Gerbauld's defect of heart. Gerbauld's defect of heart is an abnormal communication between the left ventricle of the heart and the right atrium of the heart. This is usually, sometimes it is mostly acquired, and it can be congenital, a part of a atrioventricular cushion defect. It is mostly acquired because as a result of a cardiac surgery, infective endocarditis, or due to ischemic heart defect, or as a part of after a percutaneous interventional procedures. Now, this defect can be classified as a direct or an indirect. When the defect is usually a congenital defect, it is usually a indirect. Indirect means that the communication runs from the left ventricle to the right atrium through the tricuspid valve. Whereas if it's a direct, it runs directly, communicates between the left ventricle and the right atrium. And it's further classified as supravalvular, valvular, and intermediate depending upon the relation to the tricuspid valve. Now, this is a case report. This 28 years old, Gravida 3 Para 1 Live 1, a known case of congenital heart disease. She was operated at 5 years outside. The details was not available to us. She presented with a severe valvular pulmonary stenosis and gerboid defect of 3 millimeter at 36 weeks. She had a first pregnancy with us at PSG. She had a vacuum-assisted vaginal delivery in 2016, and postnatally she had atonic PPH, which was medically managed, and postnatal period was uneventful. She was initially planned for a cardiac evaluation, but she lost follow-up. The second pregnancy, MTP, was done at 10 weeks. And in third pregnancy, she was booked outside till 36 weeks. And on admission, she was NIHA 1. She was completely asymptomatic at rest. She had mild pallor, pedal edema, and JVP was normal. And in heart, first and second heart sound was heard, and ejection systolic murmur was heard in the pulmonary area. Per abdomen, the uterus was at 34 weeks. Investigations revealed hemoglobin of 8.9. Ultrasound showed a stage 1 FGR. The echo showed a severe valvular pulmonary stenosis with P gradient more than 60 millimeter of mercury, and a gerboid defect of 3 millimeter of mercury, 3 millimeter with a left to right shunt with a pre-gradient of 109 millimeter. The blue color line, like sky blue line, is a communication between the left ventricle and the right atrium. She had no pulmonary artery hypertension. The right atrial chamber size was normal. She was induced with prostaglandins in view of stage 1 FGR, and then the labor was augmented with oxytocin. She delivered by a vacuum-assisted vaginal delivery, and then she underwent, the postnatal period was uneventful. She underwent puerperal sterilization under general anesthesia. Ma'am, is my poster present visible, ma'am?
Yes.
Okay, because it's not visible for me, ma'am. Okay, so this was about the case. And moving on to the discussion, it's a very rare congenital cardiac condition, making around 0.08% of all the intracardiac shunt. As previously discussed, it can be either due to a congenital cause or an acquired cause. Acquired
Dr.
being more
Ashwini,
common.
Can we
Yes.
interrupt you?
Yes, ma'am.
How does this differ from a left to right shunt?
It all depends upon the size of the lesion and how the previous what was a precipitating cardiac event, ma'am. If it's going to be a congenital cause, or it could be a part of a corrected tetralogy of Fallot, and if there's going to be any prosthetic patch which was used in correction, all these things matter. This was a simple case, but then this
the question is, how does it differ? Is there a difference between this condition and the usual left to right shunts that we see?
Not much difference, ma'am.
There's not much of a difference.
Much difference,
Unless there
yes,
is a
ma'am.
reversal, I guess.
Yes, ma'am. Unless there is a reversal.
This lady had a pulmonary artery stenosis?
No, she didn't have a pulmonary artery hypertension. Maybe that part could be explained because she had a congenital stenosis.
Of what?
Severe of pulmonary stenosis.
She had?
Yes, ma'am. She had a congenital severe pulmonary stenosis along with a Gerboid's defect.
But right now there was no PhD?
Ma'am?
Was there any pulmonary arterial hypertension?
No pulmonary artery hypertension.
With such a severe pulmonary stenosis?
Yes, ma'am. With severe pulmonary stenosis, she didn't have a pulmonary artery hypertension. Because there's no... Ma'am?
Yes, Raj.
It was a valvular pulmonary stenosis, ma'am.
So what will you advise her? Will it go in for an Eisenmenger, this kind of a stuff?
No, ma'am. This will not go in for an Eisenmenger syndrome.
Why?
This is because the pulmonary artery pressures are not high, ma'am. Because
when she's 40 or 45?
Ma'am?
When she becomes older?
When she becomes older, anyway, there is no overloading of the pulmonary circulation because of the pulmonary stenosis, ma'am.
Right now, it is not there.
Yes, ma'am. In the future, it can mean she needs close follow-up and she needs a definitive corrective surgery.
Just like how you advise for a PDA, ASD or a VSD, this
Yes,
was
ma'am.
similar to that.
Yes, ma'am. Similar to that.
So did she warrant any prophylaxis for infection?
No, she didn't. She didn't need any prophylaxis because there was no indication for a
Was there any
prophylaxis.
audible murmur?
She had an ejection systolic murmur because of the pulmonary stenosis.
Because of the PS, is it?
PS, yes, ma'am. The defect was very small, 3 millimeter.
Discharge.
Ma'am?
Dr. Rajeshwari.
No more questions, ma'am. It's fine.
Okay, ma'am.
Thank you, ma'am.
Oh, thank you, ma'am.
Next candidate, Dr. Shravanti Rathod.
Good afternoon, ma'am.
Yes, ma'am. Share your PPT and start presenting.
Yes, ma'am. I'm not able to share, ma'am. Ma'am, I'm not able to share, ma'am. Other participant is sharing, ma'am.
Oh, 1 second. I'll just.
Okay, ma'am.
Dr. Shravanti, now you try it.
Yes, ma'am. Ma'am, is it visible, ma'am?
Yes.
Yeah, it's
Good afternoon, ma'am. Ma'am, is it visible, ma'am?
yeah, it is visible. Proceed.
Good afternoon, ma'am. Myself, Dr. Shravanti from Nilofer Hospital, Usmania Medical College, ma'am. Presenting a rare case of 29-year-old third gravida with 2 previous section with dysgerminoma complicating pregnancy with intermediate risk category on ORAT score, ma'am. Introduction: the germ cell tumors account for 5 to 8% of all ovarian tumors, which are common in reproductive age group. Most of them are benign and unilateral tumors, whereas dysgerminoma is a malignant tumor and which is bilateral in 15% of cases, associated with lymphocytic infiltration. The markers of dysgerminoma include LDH, HCG, and PLAP, which are not much significant in pregnancy. Immunohistochemistry for OCT 34 and CD 117 and DT 40 are negative, ma'am. The patient has to be followed and need for surgery and chemoradiation to be explained, ma'am. A case report was a 29-year-old third gravida with 2 previous section, which was unbooked case, came to our hospital at 28 weeks of gestation, ma'am. Scan was done at 28 weeks, which showed 6.5 into 7.2 into 7.4 centimeters left endometrioma. The scan was repeated at 32 weeks, which showed increase in size from 6.5 to 10.5 centimeters into 7.5 to 8.4 centimeters. The features of cyst at 32-week scan were heterogeneous with solid lesion with few anechoic areas, showing internal vascularity arising from the left ovary. As the USG findings were highly suggestive of malignancy, patient was advised for termination of pregnancy, which was deferred, and the patient was advised for MRI, but she was not affordable. However, she came out, she lost the follow-up and she came to our institution at 36 weeks for delivery, ma'am. All other markers were done and found to be negative. USG findings of the tumor are at 28 weeks, it was relatively well-defined heterogeneous echogenic lesion noted in the left agnaxial region, which was arising from the left ovary, ma'am, which was measuring in 6.5 to 7.5 to 7.4 centimeters, ma'am. At 32 weeks, it was 10.5 to 7.5 to 8.4 centimeters, which was well-defined and with few anechoic areas with internal vascularity, ma'am. The patient came to us at 36 weeks. According to this, the cyst findings on the scan, it falls under the category of intermediate risk, ma'am. According to the ORAT's grading, the high risk for malignancy are 10% to less than 50%, ma'am, as it is falling into category of unilocular cyst with solid components, ma'am. The patient turned up at an institute at 36 weeks, ma'am, with complaining of pain abdomen. So cesarean section was performed and delivered a female healthy live baby of 2.5 kg. At the time of cesarean section, only left salpingo oophorectomy was done with the removal of the cyst, which was a irregular border. Right salpingectomy was also done, and exploration of other organs was also done, like omentum, liver, and spleen was sent for histopathology. Specimen and omentum sent for histopathology was normal, ma'am. The cyst was with irregular borders with a size of 10 into 10 centimeters. On histopathological examination of the cyst, it showed the features of dysgerminoma with mixed clear cell teratoma tumor, ma'am. A 29-year-old third gravida with 2 prior section with dysgerminoma complicating pregnancy. All the women with adnexal mass in the reproductive age group should be considered as differential diagnosis for germ cell tumors, ma'am. And even though the markers are negative, they should be followed up regularly with radiological findings, ma'am. In the pregnancy, as the tumor markers are not significant, and also immunohistochemistry for the stains in this patient was shown negative, but it was evident on histopathological features, and radiologically the patient was followed, ma'am. And the patient need for the follow-up should be counseled, and the chemoradiation and surgery should be explained to the patient, ma'am.
Suppose at 28 weeks of diagnosed, first time when you have a bigger mass of solid component, you have a high suspicion of malignancy in this patient. How could I be?
Yes, madam.
At 28 weeks, you suspect a high degree of suspicion of ovarian malignancy. How you could have proceeded?
Yes, ma'am.
Patient has come to you at 36 weeks, so delivery is okay. You immediately delivered her. Suppose 28 weeks or 26 weeks she is coming to you. How could I be?
If she would have come at 28 weeks with these features, we would have asked her for the termination and all for the staging laparotomy, ma'am. But we were advised the patient for MRI, but the patient did not do the MRI because she was not affordable.
Suppose the patient is saying that you had a diagnosis of malignancy.
Ma'am, sorry, ma'am, you're not audible, ma'am.
Suppose the patient is agreed for MRI and the feature is suggestive of malignancy.
Yes, ma'am.
At 26 weeks.
Yes, ma'am.
For termination, it's only the suspicion, it's not true diagnosis.
Suspicion. We'll follow up her, ma'am. We'll follow up with the regular radiological scan. We'll ask her to follow up with the regular radiological scan, ma'am.
Any role of chemotherapy?
No, ma'am. Chemotherapy is not advised in pregnancy, ma'am.
26 weeks.
26 weeks.
It's not advisable.
Yes, ma'am.
Any questions, Dr. Usharani, madam?
Yeah, we can. It depends upon the type of the tumor and the type of thing that you're doing.
You're not audible, ma'am.
Ma'am, it's not audible, ma'am.
I guess it will depend upon the type of the tumor and the type of the chemotherapy.
Yes, ma'am.
So what did you do finally for the CID now? She's still under follow-up?
Yes, madam. Yes, ma'am. The patient is still at a follow-up, ma'am. Yes, ma'am.
How many months of follow-up have you got?
Madam?
How many months of follow-up?
Patient was delivered 3 months back, ma'am. Yes, ma'am.
Right. Thank you. We'll go ahead with the next one.
Thank you, ma'am.
Thank you.
Next can be
Thank you, ma'am.
Dr. Madhura Vardhini.
Yes, ma'am. I extend my pleasant afternoon wishes, ma'am.
Dr. Shravanti, please stop sharing.
Yes, ma'am.
Dr. Madhura Vardhini, kindly share your.
Ma'am, is it? Hello.
Yes, doctor.
Ma'am, is it visible, ma'am?
No, you are visible. Your slide.
Ma'am, is it visible now, ma'am?
No, you are visible, but your slide is not visible.
One second, ma'am. Ma'am, now is it visible, ma'am? Hello.
Not yet.
Ma'am, it's been shared, ma'am.
Yeah.
Now it's seen.
Yeah.
Okay, ma'am. I extend my pleasant afternoon wishes to our respected delegates and my dear colleagues. So I'm Dr. Mathura Vardhani from Government Mohan Kumar Mangalam Medical College Hospital, Salem. So herewith I'm presenting a case of a teenage primate with undiagnosed HELP syndrome who delivered through labor natural a preterm alive baby, a UGA baby, outside a hospital. When she was referred to us, she was a case of mild PPH and jaundice complicating pregnancy. Like this only she was referred to us. On admission, her uterus was firm and contracted, but persistently there was bleeding from the episiotomy wound and all the vagina and from the vaginal walls. So she was taken up for vaginal exploration on the general anesthesia, and all the bleeders were arrested and hemostasis achieved. On admission, her hemoglobin was 4.8 and the platelet count 40,000, bilirubin value was 2.4 and INR was 2.15. So with that was elevated SGOT-PT and LDH values and with elevated PT-INR values also. So massive blood and blood product transfusion was done. So after which USG abdomen and pelvis showed MR, medical renal disease and ascites. The D-dimer was also elevated and fibrinogen was decreased on PNT2. Even after the vaginal exploration, she was again bleeding from the vaginal walls and the episiotomy wound, and hematoma was formed again and again and taken up for re-exploration under general anesthesia, after which she improvised. After which, during the course of stay in a hospital, the HELP syndrome was increasing with the elevated liver enzymes and renal parameters with oliguria was set in, and patient went in for disseminated intravascular coagulation and the MODS features were there. She was having bruises, purpura throughout, and melena episodes were there on and off. And hemolysis confirmed our diagnosis of HELP syndrome through peripheral smear study also. But for the melena, the SG and MG team suggested that it is better to go on for a conservative line of management, hemodynamically to improve the patient, and coagulopathy correction. So patient was treated with higher antibiotics and hepatoprotective agents along with pantoprazole infusion, octreotide injection, vitamin K, tranexamic acid, UDCA, silymarin, glutathione, and every management was done accordingly. So on the PNT5 patient, when she was receiving her second cycle of hemodialysis for oliguria and renal shutdown, she went in for one episode of GTCS and she was managed with IV anti-epileptics and antihypertensives. So again, after 3 days, she was unconscious and we continued our supportive management. Until then, blood and blood products were transfused accordingly. So health features all worsened. So her jaundice, it progressed up to all the other causes of jaundice were ruled out in the meantime. And on PND 5 and 6, her total bilirubin peaked to 10.5 and LDH being 2000s, INR was 2.45 and coagulopathy was uncorrected even after massive transfusions. So from pre-ND 10, her biochemical parameters showed some improvement. She became conscious, oriented, and our treatment was fine. It was having a positive effect on her. But on PND 14, she was deteriorating rapidly and through bouts of melena, and hemodynamically, she became unstable. Her hemoglobin, which was 10.5 the day one, became 5. It had a sudden drop. So this warranted immediate step and emergency.
Hello?
Mathura Vardhani, you are not audible.
You're not audible at all.
Dr. Mathura Vardhani. Dr. Mathura Vardhani.
It is hello. Hello.
Dr. Mathura Vardhani, neither your screen nor your voice is audible.
Hello, ma'am.
Yes, ma'am.
Ma'am, CT angiography showed there was bleeding
from
from.
day 14. Day 14, we are not able to hear anything. On day 14,
Sorry.
is deteriorated.
Okay, ma'am. On day 14, ma'am, is it visible now, ma'am?
Visible and your voice is not very clear.
Okay, ma'am. Is it now okay, ma'am?
Yeah, proceed.
Yes, ma'am. On postnatal day 14, she deteriorated with bouts of melena. So she became hemodynamically unstable. First, her hemoglobin was 10 grams. So this warranted immediate steps and emergency upper GI endoscopy was done, ma'am. Ma'am, hello. Is it audible, ma'am?
No, it's not clear.
Madhurmati, you can switch off your video if you have a poor network connection.
Madhuravartini.
Shall we discuss one more candidate and get back to her?
Dr. Madhuravartini. Shruti ma'am.
Yes, ma'am.
Ma'am, can we stop sharing this and move on to next candidate, ma'am?
Yes. Dr. Madhuravartini.
Ma'am, hello.
Dr. Madhuravartini.
Ma'am, hello. Ma'am, sorry, ma'am. I lost connection in the middle. Hello. Hello, ma'am.
Madhura, you can switch off your video if you have a poor network connection.
Okay, ma'am. Ma'am, is it audible now, ma'am? Sorry.
Yeah.
Okay, ma'am. Ma'am, on PNT 14, the patient had bout of melena. And
So
she was...
so what was your final diagnosis, Madhura?
Ma'am, upper GI bleed, ma'am. She was bleeding
For the whole pregnancy.
from the second part. Ma'am, the patient had HELLP syndrome. So she went in for MODS, sepsis, and DIC, ma'am, for which we went in for interventional radiological procedure, ma'am. Coiling embolization of the right gastroduodenal artery and proper
How can you prevent all these things?
Ma'am, initially the patient was diagnosed with gestational hypertension just 12 days before her delivery, ma'am. So patient
How many weeks did you
had
have
to be
of gestational hypertension?
Ma'am, patient presented to us in the postpartum period only, ma'am. It was diagnosed in a private setup. So she was treated.
Was she diagnosed?
Ma'am, at 34 weeks, ma'am.
34 weeks, she had gestational hypertension.
Hypertension. Yes, ma'am. Then in the postpartum period only we received the patient, ma'am.
The
After which
is not mentioned about the BP. How was the BP throughout? It was not mentioned in your presentation.
It was elevated. Yes, ma'am. No, ma'am, it was not elevated in the initial stages because she had active bleeding. She went in for hypotension, ma'am. After the bleeding had settled, after the re-exploration was done, her BP was on the rise and antihypertensive was given, ma'am.
Is there albuminuria on admission?
Ma'am, she had, ma'am, 2+, ma'am.
So you still call it gestational hypertension?
Yes, ma'am.
So what's the difference between preeclampsia and gestational hypertension?
Ma'am, with end organ damage, it is preeclampsia, ma'am. Renal albuminuria will be there, or any features of eclampsia.
Preeclampsia, you will use the word preeclampsia.
No, ma'am. In case of BP more than 160/90 with associated features of oliguria, albuminuria.
Patient had all this when you received.
Ma'am, yes, ma'am, she had, ma'am.
So what was your diagnosis and when you received her?
Ma'am, she had complications of HELP syndrome.
She had preeclampsia.
Ma'am?
She had preeclampsia. Can you say that she had preeclampsia when you received her?
Ma'am, she had preeclampsia, ma'am.
Not gestational hypertension.
No, ma'am, not gestational hypertension, ma'am.
So she went in for all the complications of severe preeclampsia.
Yes, ma'am.
Right?
And the active arterial bleed
actually.
Yes, ma'am. And the active bleeding, actually, we did coiling embolization, ma'am. From Salem, we took the patient to Chennai. We did an interventional procedure there. But even after the procedure of gastroduodenal artery embolization and the proper hepatic artery embolization, she did not improve, ma'am. Again, we took up as a last resort. The patient was took up and the proper hepatic artery, the whole thing was
You're again losing contact with you, Madhura.
after which only she showed symptoms of recovery, ma'am. After the recovery, her BP, ma'am.
Yeah, proceed.
Hello, ma'am. Yes, ma'am. After the second procedure, only her hemodynamics were stabilized. So her BP again shoot up after the hypotensive episode, ma'am. Again, it was 150, 100. After the bleeding was
interval is all this, Madhura, from delivery to all these things? What is
delivery till the intervention? It was 14 days, ma'am. On the 15th day, we did the first procedure. On the 17th postnatal day, we did the second procedure, ma'am. After which only, yes, ma'am.
Also did an embolization and
yes,
then
ma'am.
recovered.
Yes, ma'am. She recovered well. She responded well. Again, on the postnatal day 20, we did a repeat OGD scopy and repeat CT angiogram, which showed no leak. And during OGD scopy, there was a 0.5 cross 0.5 centimeter ulceration in the second part of the duodenum, ma'am. So probably the ulcer eroded and the gastroduodenal artery was torrentially bleeding into the duodenum, ma'am. So that was the probable reason, ma'am. Now the patient is stable. Today is the postnatal day 37 of the patient. She has been discharged successfully with a hemoglobin value of 10.5. Total bilirubin was 1.2, and PNR, PT-INR values all normalized, ma'am. Urea creatinine values also normalized. The patient is a very good condition now.
So how many dialysis did she go through?
3 dialysis, ma'am.
Wonderful. It shows that you should never give up on any of our bleeding patients. It's been done well. Thank you. Anything else, Dr. Rajesh?
Yes, ma'am. Thank you so much.
Oh, good.
Thank you.
Thank you so much.
Your presentation also went on and on, resuscitated and resuscitated.
Yes, ma'am. Ma'am, actually, as a last resort, only the interventional radiologist gave a try, ma'am, because the patient was only 19 years age. We just wanted to give a try to stop her bleeding episode, ma'am, because only 4 grams of hemoglobin was there when we did the procedure. So in total, 25 PRBC, 72 FFP, 24 cryo, 30 platelets were totally transfused, ma'am, for that patient.
Very good, very good. Congratulations
Thank you so much,
to the whole team for doing
Thank you
that
so much,
wonderful
ma'am.
work. Thank you.
Thank you, ma'am.
Thank you, ma'am. Next candidate, Dr. Satyashila.
Yes, ma'am, I'm ready, ma'am.
Start sharing your PPT.
Okay, ma'am. Is it visible, ma'am?
You can enlarge the image. It's very small.
Yeah, we can see it. What is this? Supposed to be your cell phone, huh?
Ma'am, yes, ma'am. Hello.
You're all doing old men. Okay, can present.
Okay, ma'am. Ma'am, good afternoon, everyone. I am Dr. Satyashila, Department of OBG from KIMS and RC Maduradagam. I am presenting a case of extrauterine adenomyoma. So about the introduction of the case, adenomyosis is the most common, is the presence of endometrial glands and the stroma within the endometrium. So the focal and the localized form of adenomyosis is called adenomyoma. And now I'm going to the case report. So we have a patient called Mrs. Sumati, wife of Mr. Linganathan, a 26-year-old Nalli Gravida from Vinayaganallur, who belonged to low socioeconomic status class 3 and came with the complaints of lower abdomen pain for 3 weeks. And the patient was apparently normal before 3 weeks, and then she developed lower abdomen pain on and off for 3 weeks, which is gradual in onset, pricking type of pain, aggravated by work and related by taking rest. So history of menstrual irregularities were present, and attained menarche at 13 years, and her cycles were irregular by 5/60 day cycle. And she changes 2 to 3 pads, and she's a known case of hypothyroid and a thyroid of 50 microgram. And she was under infertility evaluation in our institute. And on her examination, her general conditions were normal, and her para-abdominal examination was soft, no organomegaly, diffuse mass of size 10 cross 12 centimeters felt in the right iliac fossa and right lumbar region and around the umbilicus, which is firm in consistency, and side-to-side mobilities was present. And her lower borders were not felt. And on perspeculum examination, cervix vagina is healthy, and per vaginal examination, cervix is pointing downwards, and uterus is anteverted, normal in size. Right fornical fullness and tenderness was present. Left fornix was free and non-tender. Grooves and could not be elicited due to her tenderness, and all the basic investigations were normal. And her ultrasound abdomen and pelvis shows a large mixed echogenic cyst of size 10 cross 12 centimeter is noted in the right adnexa, probably of right ovarian origin, which is a complex cyst, suggested MRI and CA-125 for further correlation. Her CA-125 was markedly elevated, which was 1132, and then other tumor markers were normal. And MRI pelvis shows a right ovary measures of about 3 cross 3 centimeter with the dominant follicle and a large, well-defined mixed signal intensity lesion measuring 6 cross 12 cross 14 centimeter with a lobulated outline seen arising from the right ovary. The lesion shows a multiple cystic areas of varying size and shows a bright signal in T1W images, and then mildly hyperintense in T2W images. So impression is large exophytic abdominopelvic lesion arising from the right ovary. And then we planned for staging laparotomy done by an oncologist. So and the laparotomy findings were a complex mass of about 12 cross 14 centimeters seen arising from the fundus of the uterus, and then adhesions were present from the mass to the right ovary, to the rectum, and to the bladder, and the same were released. So right ureter is adherent to the mass and the same dissected, and then the mass delivered out, and then the body of the uterus was normal. Right ovary is enlarged and cystic, left ovary was normal, mass clamped and ligated. And then after releasing all the adhesions, we delivered the mass, and then peritoneal fluid and all the mass sent for HPE. And our HPE report shows a globular mass shows a lesion composed of endometrial gland and stroma surrounded by curls of about benign spindle-shaped cells and abundant eosinophilic cytoplasm and elongated regular nuclei. And then endometrial glands are surrounded by pseudostratified columnar epithelium with the focal areas exhibiting mucinous metaplasia. Many places shows a collection of hemosiderin ladder macrophages and inflammatory infiltrate surrounding the endometrial glands. So areas of hyaline degeneration and edema evident amid the smooth muscle fascicles. And then about discussion, so extraheteroadenoma is a very uncommon entity. So various theories of pathogenesis have been suggested that the development of extraheteroadenomyosis, multifactorial, Mullerian duct fusion defect, and smooth muscle cell metaplasia and subcoelomic mesenchymal metaplasia theory and embryonic origin. So no conclusive predisposing risk factors have been described. So preoperative diagnosis is challenging. So HP is the gold standard and surgical excision is the choice of treatment.
So you didn't do a hysterectomy, you just did the adenomyomectomy.
Ma'am, she's yes, ma'am. She's actually 26 years nulli gravida, ma'am. She was had her infertility evaluation only, ma'am, and just she for abdomen pain we did USG, and then we had just is because of complex mass we did tumor markers, ma'am. Only CA-125 was elevated and the other parameters were normal, ma'am. So we did MRI and everything, ma'am, and then we did a staging laparotomy, ma'am. In that we
Did you do a frozen section for her?
Ma'am,
Parasitic fibroid.
ma'am, yes, ma'am. It. Sorry, ma'am, I couldn't hear you.
Is it a parasitic fibroid? She's asking.
Yes, ma'am.
Parasitic fibroid, Kekra.
Whether it's a parasitic fibroid or able to differentiate whether it is a parasitic fibroid or it is a adenomyoma extrahepatic is very, very rare, isn't it? Parasitic fibroid is also rare, but it's rarer.
Yes, ma'am. Extraheteroadenoma is very rare.
So how are you going to differentiate? Of course, by histopathology only.
Yes, ma'am.
Total differentiating features, I must say.
Ma'am,
Yeah.
parasitic fibroid, ma'am. Parasitic fibroid will be arising from the uterus, ma'am, and it will be wandering fibroid. Mostly it will be subserosal fibroid.
No, when you are diagnosed with parasitic fibroid, there will not be any attachment to the uterus.
Okay. Mostly it will be subserosal fibroid, ma'am.
What are the theories regarding what will theories regarding the, what is it called, extrauterine adenomyosis.
Ma'am, we have yes, ma'am. Multifactor mullerian diffusion defect, ma'am. Smooth muscle cell metaplasia, subcoulombic mesenchymal metaplasia theories, ma'am, and embryonical origin.
I think. Thank you. Any other questions, Dr. Raj?
No, madam. No, madam.
It was an interesting case. Thank you.
Okay, ma'am. Thank you. Thank you so much.
Thank you, ma'am. Final call for Dr. P. Sushma Shri. P. Sushma Shri.
You're giving her a final call for the flight.
No, ma'am, it's over, ma'am, already. The missing candidates are, I'm calling out, ma'am.
Yeah, go ahead, go ahead.
Dr. Neha Karen Fernandez. Dr. Neha Karen Fernandez. Dr. Reshma Meena. Dr. Reshma Meena. Dr. Purnaveni Mohan. Dr. Purnaveni Mohan. Dr. Kavya. Dr. Kavya. Thank you for all the participants. Thank you, judges. This is the end of the session.
Dr.
Yes, ma'am.
Lavanya, out of 20, we have only 11 is presented. Is it right?
Ma'am?
Out of 20, only 11 is presented, and you are going to close the session. Is it okay?
Yes, ma'am. Yes, ma'am.
Yeah.
That's all, ma'am.
And do we send this papers, ma, for the marks?
Ma'am, in the group, ma'am, you can post it in the group, ma'am. Judges group is there, no, ma'am. We can post it there, ma'am.
Thank you.
Thank you, judges. Thank you, ma'am, for your patient cooperation. Thank you, ma'am. Thank you so much.
I'll call you to finalize the result, madam. Dr. Usha.
Thank you.
Yes, ma'am. Thank you, ma'am. We'll end the session now, ma'am. Thank you.
Thank you.